The Department of Health, DOH, Department of Science and Technology, Philippine Council for Health Research and Development, DOST PCHRD, and the Ateneo de Manila University Institute of Philippine Culture, ADMO-IPC, are providing this webinar as a public service, but it is neither a legal interpretation nor a statement of DOH, DOST PCHRD, or ADMO-IPC policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by the DOH, DOST PCHRD, or ADMO-IPC. The views expressed by speakers, facilitators, and viewers are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Views and opinions expressed by DOH, DOST PCHRD, or ADMO-IPC employees are those of the employees and do not necessarily reflect the view of the DOH, DOST PCHRD, and ADMO-IPC, or any of its officials. Ladies and gentlemen, welcome to Session 3, Part 1 of the 2020 National Health Research Forum for Action. Our session moderator and facilitator for today is Ms. Michelle May Daabay, the Learning and Development Officer of the Health Policy Development and Planning Bureau of the Department of Health. Ms. Daabay.
Good afternoon, everyone. The Philippine Standard Time is 1:01 p.m. Welcome to the 18th National Health Research Forum for Action. This year's forum aims to showcase local evidence, breakthrough findings, and development and health policy and systems research geared towards the realization of the universal healthcare and the context of the current COVID-19 pandemic in the Philippines. We are now in the session 3 of the forum. Just a quick recap of the past sessions. Session 1 focused on the discussion on transparency and accountability in governance in the face of COVID-19. The session 2 discussions focus revolve around the strengthening of local health system. Today, session 3 will deep dive into the theme titled Ensuring Continuity of Health Service Delivery Amidst the Public Health Emergency. Please take note that the session 3 is divided into Part 1 and Part 2. Part 1 will focus on the two important elements of health service delivery, the health workforce and the health facilities. Tomorrow, we will continue on the Part 2 of the session, zooming in to the special populations, the overseas Filipinos, the elderly, and the children. Once again, I welcome you to the forum. Thank you for joining us today. To formally start the program, we will have a short prayer.
Let us put ourselves in the holy presence of God. Father in heaven, always merciful and giver of life, we humbly ask that you bless each one of us, from the speakers, program committees, guests, and participants. Guide us to make better decisions as we incorporate what we will learn throughout this activity. Thank you for the infinite blessings and countless opportunities. Lord, today as we start our activity, may we always be grateful to learn new things. Shed the light of your wisdom and bless each one, especially our speakers, as they will share their knowledge to us. Through your mercy and grace, may peace and utmost understanding shine and dwell unto us. Almighty God, accompany each one and help us concentrate for us to gain more knowledge as we listen attentively. This we ask in your name. Amen.
I know everyone is excited to start the discussion, but let me just welcome the participants who's just checked into the platform. Good afternoon. Before we formally proceed to the presentation, These are the webinar rules we want you to be reminded. First, if you encounter connection problems during the webinar, please click the Reconnect button found at the top of your screen. Second, please use the chat box on the right side of your screen for questions and comments related to the webinar at any time. They will be read after the presentation. Third, please state your name and affiliation with your questions and comments. And the last one, the very important rule, we value respect and courtesy the most during our webinar sessions. To give us a picture how services are delivered amidst public health emergency of COVID-19 pandemic, an illustration using TV services will be presented by Dr. Ana Marie Selena G. Garfin.
Good afternoon, everyone. I'll be making this presentation. The Health Service Delivery Situationer and illustration using TB services on behalf of the Public Health Services team. So the objective of this presentation is to illustrate how services are delivered amidst the public health emergency of COVID-19 pandemic by using TB as a tracer program. All health services are affected by the ongoing pandemic, and the illustrative examples and policies for the National Tuberculosis Program will likely mirror the situation of different programs and health services. So TB case finding is a core strategy of the National TB Control Program. Through screening and testing, we diagnose and treat active TB cases and prevent further transmission, resulting to overall decrease in the incidence. This is what we want to achieve for the TB control program. The COVID-19 pandemic has significantly compromised the case-finding efforts of the country. The effect was immediate, with daily detection number markedly declining during the first 10 days after announcement of quarantine. This was shown by a modeling done by the University of California. So this is the graph that would show that. And then the effect was also sustained with the STOP TB modeling showing a continued low level of detection in the next 3 months following the quarantine, as shown here. So the upward trend illustrated here from the STOP TB modeling is just a projection of an ideal recovery phase wherein we are able to resume and intensify case-finding efforts. So let us now look closer at the effect of COVID-19 in the cascade of care. So this is based on the rapid assessments made by the USAID-supported projects, TB Innovations and TB Platforms. For screening, there was no active case-finding activities because of the restriction in the movement of the patients. For testing and diagnosis, testing was stopped due to lack of PPEs and there was restriction in the transport of the specimens. For treatment, there was restriction in the movement for clinic visits. And for the prevention component, contact tracing was limited because of quarantine. The big question now is, how do we recover and offer services in this pandemic? So last April, the Department of Health issued these guidelines on risk-based public health standards. It provides the mitigation measures according to 4 major objectives of the new normal. When the NTP developed its plan for delivering services during the COVID-19, these were the standards that were followed. So let me review the salient points briefly. So there are 4 main objectives to mitigate COVID-19 transmission. So we have objectives 1 to 4, physical and mental resilience, reduce transmission, reduce contact, and reduce duration of infection. Across each objective, but mostly within objectives 2 and 3, there are relevant guidelines that serve as backbone of the TB adaptive plan. These include the following: We encourage symptomatics to stay at home. So we do virtual consultation, rational use of PPE suitable to the setting, strict physical distancing at all times, restrict unnecessary mass gatherings, reduce movement within and across areas, install architectural or engineering interventions as appropriate, and teleconsulting platforms. Using the new health standards as basis, the NTP with the different stakeholders reviewed the current strategies and procedures of the program and identified the necessary changes to be implemented in the resumption of TB services. The output was the NTP Adaptive Plan, or what we call the NAP. So the NAP has already been approved by both the TB Technical Working Group and the DOH Execom. So this will be issued soon. There will be a full, more detailed document that will be issued and can be accessed through the NTP website. That is the ntp.doh.gov.ph. As mentioned, the NAP is anchored on the minimum public health standards, and the core principle is that all facilities and providers shall observe minimum public health standards to mitigate measures for COVID-19 response. It provides not just general guidelines, but also doable actions at the service delivery. Examples are embedded in the annexes. So we have the infection, prevention, and control operational guidelines, what PPEs for specific TB control activities should be used, and types of masks to be used based on the different settings. So through the NTP Adaptive Plan, we provide guidelines on how to resume all screening and contact tracing activities. So this picture here illustrates the old normal in an active case finding screening activity. Active case finding is bringing TB screening and diagnostic services to the high-risk community or settings, and this is best suited for those with marginalized access to health services. The DOH recognizes that these activities are essential and have to be resumed as soon as possible. To do this, we revise our procedures according to the new normal standards. Hence, the new guidelines incorporates physical distancing, IPC or infection prevention and control procedures such as use of masks and regular disinfection of areas, and screening of both presumptive TB and COVID-19 suspects for early detection and separation. Another salient point of the NAP is the upgrading of biosafety guidelines for some NTP procedures. For example, before we recommend only the use of gloves and masks in the performance of a TB test, like the expert, which involves sputum as a specimen. So we know that having a sputum or touching the sputum can increase our risk for COVID-19. So under the NAP, stricter standards are recommended. While it can still be performed in a bench without biosafety cabinet, the use of appropriate PPE to include laboratory coats, safety goggles, and respirators are now included. So we want to have our health workers, especially the medtechs, to be safe. Lastly, one of the objectives of the new normal standards is to reduce contact between clients and health providers. TB services are probably be considered as one of the programs with intensive provider-patient interaction. This is because we used to implement the directly observed treatment, or what we call the DOT, wherein patients see a provider and take the daily dose in front of them. While we have already revised this prior to the pandemic, with the adoption of more patient-centered approaches, the new standards has fast-tracked this change for the NTP. So given the recommendation to minimize physical contact from frequent visit to health facilities, these are some of the new procedures emphasized in the NAP. So we do community and home-based treatment. So we do that instead of facility-based, so patients can already take their treatment at home. Provision of at least 1 month's supply of drugs to the patients, And we also introduced the all-oral regimens for our drug-resistant TB cases. Before, we still have the injectables for our drug-resistant TB cases. But now we are using all oral regimens for drug-resistant TB cases. Then we also have the digital adherence technologies and tapping family members as treatment partners. Consider virtual or electrophonic consultation. Follow-up smear microscopy may be done in peripheral facilities with complete PPEs. While the NAP was developed to address the challenges of providing services during the COVID-19 pandemic, there are concerns that require further health system support in addition to the technical guidelines. So I will present two examples. First, COVID-19 has brought new demands on our health systems, and this will displace other health services. As an example, in our TB culture laboratories, testing for COVID-19 requires laboratories with biosafety level 2 standards, or what we call the BSL-2. Since our TB laboratories are BSL-2 certified already, many were repurposed for COVID-19 testing. As a result, to date, out of 30 TB culture laboratories within the NTP network, 20 are doing COVID testing, and 13 of these have temporarily ceased doing TB tests. So we asked our health workers what are the reasons, and they gave us several reasons for stopping TB culture testing. On initial consultation with them, the lack of manpower to do both testings were what they informed us. So this is an example where additional health system support, either manpower or infrastructure, are needed to meet both new demands of the COVID-19 and the sustainability of previous services for TB culture. Another example that requires health system support is the emphasis on infection prevention and control, hence requiring our PPEs. So the NAP provides the guidance on what specific PPE is required for different NTP procedures, as well as PPE required for TB testing. But to ensure this is implemented, additional funding is required. Part of the NAP exercise is to identify additional cost items under the new normal that were previously not included in the costing of the Philippine Strategic TB Elimination Plan. So this table here is taken from the NAP document and shows additional investment required for 6 months of 2020 and the entire 2021. Note that PPEs and IPC are the two main cost items that require additional support. This is part of the new normal that health services will have to contend with. So in summary, the following are the key points in moving the NAP forward. We should recognize that TB services are essential and need to resume as soon as possible. We need to integrate new health standards in all aspects of the NTP operations, and additional investments are needed to cope with COVID-19 new demands on existing infrastructure and services. While these are illustrative of the National TB Control Program, they can probably be considered for all other health services as well. So this is all for the TB program. Thank you.
Thank you, Dr. Garfin, for your presentation. This presentation actually gives a reassurance to the general public that despite the present situation, the health service delivery will continue. This is to inform everyone that we will be entertaining 2 questions for Dr. Garfin. Dr. Garfin, are you still there po? Okay, this is the first question po. It is said that it is very good to know that NAP provides for the marginalized also, but in light of the pandemic, does the DOH provide additional facilities for treating TB patients belonging from GIDA? This will limit the need for them to do cross-border travels by localizing their access to treatment.
Okay, so TB services are available in all health centers nationwide. So this is one of the program of the Department of Health that is present in all health facilities. So we don't need additional facilities to provide the TB services. And one of the initiative of the program is we do active case finding. So we identify areas that needs screening for TB, and we go to that area. So we schedule activities. And maybe one of the limitation now is the requirements that there should be social distancing. So that is what we are planning with the different coordinators of the regions, the provinces, and the cities. How can we do our active case finding? And this activity is supported by the Global Fund. Over.
Yeah, okay, thank you for that, Dr. Grafine. I hope Dr. Grafine is able to answer the question from one participant. There's another question to Doc. The question is, given that there's a veering away from DOTS, how do we monitor compliance? Also, how do we assure that the supplied medications are not sold?
Okay, so how do we ensure that patients are taking their drugs? The health workers do home visitation, and one of the initiatives that we're doing is we're using the digital adherence tool. So this is through videos, or there's a special package wherein there is a number that the patient should call if they have taken their medicines. So there are new innovations that are being implemented by the program with the different partners. In how do we ensure that they are not sold? So we do random check, we do monitoring, but we cannot really assure everybody that they don't sell their drugs. Maybe what the program is doing is we advise them, we guide them that the taking of the drugs is very important for them to be cured completely.
Okay, that is the question po of Mr. Gaudencio III, Ligutam Itan. Hi, sir. I hope Dr. Grafine is able to answer your question. Doc, will we be entertaining one more question po? Is it okay po with you?
Yes, ma'am.
Okay, the question is, do you have current research on TB and traditional medicine? That is the question po from Mr. Sol Hidalgo.
Come again, ma'am. Hindi clear.
Yes po. The question is, do you have current research on TB and traditional medicine?
Wala po. Traditional medicine, no. But the researches that we're doing now are for the use of new drugs. Pero walang traditional medicines.
Okay. Thank you, Dr. Grafine. That would be all for the Q&A. Thank you for sharing your expertise with us, Dr. Grafine. Let us now proceed to the presentation of researchers. Today, we will be joined by 3 team researchers. Each presenter will be given 20 minutes to discuss their studies. Each presentation will have a reactor. For the first part of, after the 2 presentations, there will be a reactor. That is Dr. Rojas. He will be given 10 minutes to do that. And after the reaction, there will be 10 minutes for the Q&A. To introduce the first presenter, Dr. Angelita Gregorio Medel. She is a lecturer at the Ateneo School of Government. And she is also an independent consultant to various international and local development agencies and institutions. Today, she will be presenting her study entitled HRH Master Plan Strategies 2020 to 2040 for Universal Healthcare. Welcome to the forum, Dr.
Okay.
Dr. Medel.
Yes, good afternoon, everyone. Magandang hapon, tanghali po. Let me just clarify about I am really a part of a team. I'm representing a health system strengthening team, next slide please, that is actually building on the lot of work that has been done on the HRH, or the Human Resource for Health work in our country. This has been going on for years, and there was an important impetus to update this because of the COVID situation, respecting that the impact of this pandemic has caused deep and broad results and demanding changes from the health system and the entire country and the world. It was important to update this, so there was updating of the situation analysis to validate what has already been identified. Now, currently, it is the WHO is helping advance the work, but there are a lot of people behind this, like USAID and other local national experts who has contributed to this. Let me just acknowledge this, and that it is important to underline too that this master plan is being heavily guided based on the trajectory of and the principles of our own universal healthcare law, as well as being guided too by the Formula 4+1 strategic thrust of the DOH. And all this, as you know, is under the umbrella of the Philippine Development Plan and the Ambition 2040. Now, what happened when we updated this, I think it is no longer a surprise if I will tell you that there is the COVID situation has affected us, more importantly, as a country and as a people of the world. The health budget itself, although it has not increased as much for the 2020 allocation, has actually been fueled by additional funding for the COVID response. This is an opportunity, but at the same time, it also allowed us to really be more conscious about pandemic preparedness. However, there are also challenges, like, as you know, in the news, the integrity of the health financing, which is very critical to UHC, and even the promotion of the human resource for health has also been compromised. All this is contributing to a very serious economic downturn. The projection for the next year is very bad for the country even. There is very much a constraint in resources available not only for health, but all the other support systems for health. The effect on the education and other sectors is already being seen very, very concretely, and therefore the need for plan revision. Now, I know that people will ask, why plan if we cannot ascertain or cannot even use the old plan strategies? We can never predict what is going to happen. I think they always say that without a plan, you're like a blind man. At least with a plan, you're able to anticipate and prepare for what would come. It will serve as a guiding post, not necessarily as a static and rigid roadmap, but it will help us navigate our way, especially when there is so much uncertainty in this VUCA world. Now, one of the things that came out very, very clearly is the insufficient digital technology service that has hampered a lot of support and frontline work in COVID response. Next slide, please. What is exactly being highlighted in our COVID situation update is that in relation to the health, the workforce for health, is that there is serious insufficiency in terms of not only the number, but also in the welfare and protection concerns. This is very clearly already pictured and characterized by Dr. Grafin in how the tuberculosis response has actually been very greatly impacted by PPEs and other gaps in the health system. The other concerns and the weaknesses identified are actually very much connected to already what has been there for so many years. The lack of HRH, the inequity in the distribution of our health workforce, the lack of policies, the gaps in the policies on HRH, etc. Now, what did our situation updates show? It is highlighted and exacerbated. And what concretely were these? One is governance and accountability. Two is the data systems and info management, as you would already know better than I would, that there is really a whole problem in all the tracing, so that because also of the lack of integration of health information systems, even within government agencies, nationally and locally, and even between government and those already helping out from the other sectors of society. There is, as I said, already also the policy gaps, and not only the policy gaps, more so the implementation of some very good policies already in existence. Now, one other thing that came out very strongly is that the human resource for health management functions has a lot to be desired in our bureaucracy. And I'm not speaking only of the health agency, but also across, because there is a need for an inter-agency and convergence from even the oversight to the other support agencies that will strengthen HRH. Highlighted very strongly during this COVID is that there is a need to attend to the welfare and development and safety of our human resource workforce and professionals, because ultimately this is a major factor that affects the quality and the sufficiency of health service delivery in this country. Next, please. Now, what are the insights we can draw from here? The insights that will have to be highlighted in this is that, first, hands down, UHC has come not early enough. I mean, it came to us and it was approved even before COVID came, and there is really good groundwork already done. Therefore, the relevance and urgency of UHC has been very, very much underlined. And you would know, too, that the thrust of primary care is now the battle cry in responding to even future pandemics or future future problems like COVID. The lessons that has been learned in the past, whether it's HIV, SARS, and other, could be actually capitalized. The other one is the alignment, collaboration, teamwork, and decentralization of HRH via a multi-sectoral platform. It is not, cannot be denied that every bureaucracy, especially government bureaucracies, because of its very nature, its size and its scope, tend to be really very affected by one of the vulnerabilities of bureaucracy, and that is a tendency to go siloed. And that is not going to help us even in the future of strengthening the health system and responding to future pandemics. Another one that really very strongly, again, I will emphasize, is about data. And more than data is technology. Our entire country is very much beleaguered by internet connection, and this is an important, an urgent and important dimension in attending to health system improvement. Again, I underline the centrality of the human resource. No policy, no technology, no system, and no facility will be good enough without the HRH there at the forefront. Competent, committed, and systematically mobilized will be the important message here about the centrality of HRH. Next slide, please. Now, what seems to be the direction in navigating towards the better normal? The emphasis that has the emphasized aspects in these consultations we did, just to update what's already been done on the strategy, on the master plan, is you can see on this figure, on the vertical line, you will see the oversight regulation, and down there is the accountability. It is very important that there is, whether it's called DBM or the civil service, oversight and regulation has got to be in place, because that is the only way to strengthen the practice and behavior of accountability, and to make the system and mechanisms of accountability work, whether it is vertical or the horizontal accountability of convergence and interdependence that you will see on the horizontal line. Because even if you have data and information, if you are not practicing good governance of transparency, participation, and accountability, then I guess the whole idea of gaining the trust of the public is going to be further eroded. Not only that we have data, and that not only that people are convergent, systems are interoperable, and mechanisms of accountability are working. The people at the front line running these mechanisms, putting in the whole content and process of convergence and using data for management for decision support has got to be competent, and not only competent, committed. This is the core message of how it is, what it means to navigate. In the figure here, you will see that at the center of the circle is actually just showing you the whole meaning of dynamism. It can never be static. With changes happening almost every millisecond, we, as people who would like to be on top of our own development and growth, has got to be mindful of the changes that is enveloping our lives. There is something very constant here. The whole management and system of planning, financing, implementation, whether it's of policy on the legislative or executive level, are all part and parcel of it. But more than ever now, what is being called for is partnership, interagency work through coalition building, a very strong emphasis on regulation and enforcement of policies through regulatory mechanisms, a systemic and a use of dynamic structures that will be able to attend to the core pillars of human resource development and management, which is recruitment and selection, which is placement and promotion, which is also welfare development for all purposes of retention and career development, and the continuing education and protection. Now, what is important here is, if you see on the left side of the left lower side of this almost quadrant circle, is you look at education of HRH workers and professionals that actually emanate from the education sector, or even down there in the family upbringing. After they have finished their education, they move to qualification and continuous learning. This also intimates to you the necessity and importance of looking at it from a labor market perspective. Next slide, please. Next slide, please. The next slide will actually show you how HRH master planning must be viewed as a social system. Here, the emphasis that has come out is that leadership can no longer be about rock star leadership. Leadership in this time, this time of a VUCA, volatile, uncertain, complex, ambiguous world, necessitates shared leadership that is characterized by one, network team approach, which is, after all, the whole theme of the UHC when you look at the network and referral system in service provision, collaboration platforms towards social shared responsibility, practical and agile management. It can no longer be the static kind of management that has been there for so long in many of our bureaucracies, because that is the only way to provide for accountable governance. And more than anything, it is the trust of our own health workers and health professionals, as well as of our public, so that we as a people can actually reach out and work as a team, but also autonomously, committed and innovative, all towards reform. The fundamentals of this will mean not only an agile network, but also silo-busting collaboration, commitment building through relationships, accountable governance, and again, trust and autonomy. Next slide, please. I'm sorry, just a cue. Right, now, there you go. I thought I'm not, okay, thank you. The next one is just to show you what has been drafted as the HRH vision statement and mission statement. The Filipinos, hopefully by the end of 2040, Filipinos already access responsive health services anchored in primary care practices in the light of the thrust of UHC, networked approach provided by an adequate and equitably distributed, competent and committed HRH in the health sector, who with their decent and supportive work environment enjoy the dignity of their work. The mission, who is then? This we appeal to you and I appeal to you. This is not about DOH alone. Neither is it about the HRH network that has already been organized. It calls on everyone with a heart for the people, with a commitment to improve this country, to embrace that mission of ensuring sustainable production, equitable distribution, and continuous development of compassionate and responsive human resource for health at all levels, to deliver health care to the continuum of promotive, preventive, curative, and rehabilitative health interventions. Next slide, please. And in this next slide, I am presenting to you actually the 20-year time frame. I'm doing two slides, the 20-year time frame and the 10-year time frame. I know you will say, in this day and age, why are you going to do a master plan until 2040? But again, I say that I know that the present planning is always saying do short term because we don't really can tell about the future. But I think the wisdom in doing long term is that you're able to at least paint the horizon, whether you're right or wrong. That boldness of doing the necessary work to look beyond our flat noses as Filipinos will help us build the vision towards which we can work. And here in this next slide is the time frame for the 2020 time frame. What is the impact or the whole umbrella by which we would like to be able to be guided? It's of course the healthier Filipinos via improved health outcomes and responsive health system performance. So it's not only about health outcomes. We know very well that the whole system needs to perform. And we are sure that this could happen only if within this period of 2020 to 2040, adequate number of competent and committed human resource for health are equitably distributed in the health sector. This is an ongoing problem for decades. You know very well that there are many areas where we do not have the necessary health workers or health professionals. That's why we shortchange in the delivery of health services. For this to happen, we need an intermediate sectoral outcome. I believe that for the long term, we will need to be able to work across sectors, but at least in the intermediate, the whole health sector should come out with one. Produce highly skilled, motivated, and productive HRH. And this necessitates a very streamlined and very strong link between the education and the health sector. Two, to build a cadre of health professionals, competently navigating and reforming the health system for a stronger integration of its building blocks of financing, service delivery, health information, access to health technologies, leadership, and governance. So in the intermediate, we always believe there should be an important community, a cadre of professionals who will see through the advocacy, whether thick or thin, will make sure that HRH agenda is being advanced. On the organizational outcome, and I mean organizational, we are looking at this for across agencies, stakeholders in the HRH, and even the allies from the private sector, the academia, and the civil society groups. What are we asking? One, clear and enforced standards for HRH production, workforce planning, development, exit and re-entry across involved sectors. And I emphasize this, please. It cannot happen that one agency or one sector alone will do this. We need to see this at the organizational level. Second is the integrated sector-wide HRH management system structures and collaborative platforms. HRH systems cannot happen only again in the HRH. We need to be able to strengthen our HR as generic as also more so HRH for health, because that is the only way for which we can advance the improvement in the health system. Finally, on the organizational outcome, data. We need data-driven, people-centered HRH systems in the design and management. So it's not only in running it, in conceiving it and imagining it, we need to make sure that we're talking about people, the stakeholders, the public, the HRH personnel and professional, but more so it has to be data-driven. Why? Because on the program level, if you look at it, we need to be able to advance evidence-informed policy levers to strengthen the national health workforce data system or the systemic setup so that the HRH standard systems and platforms from production to exit and entry will have policy levers, or what I call, we're in a bureaucracy. This is government. And the only way for anybody in the bureaucracy and the government to really move is to have a budget. And for us to have a budget, we have to have policies. Second is a synergistic accountability mechanism across HRH management structures and systems, meaning driven by data, well or evidence-informed policy, and committed and competent practice. Finally, on the program outcome, we need interoperable HRH information system anchored on effective data governance for decision support. Now, I'm being challenged here. I'm being told that interoperability is something that we have to gun for long term, because the first step is integration. Be that as it may, I would always say that we will never forget that integration is not systems talking to each other. Interoperability is what we need when we can really have one system by which to analyze our situation and to project where we're going so decisions are well informed. Finally, the foundational outcomes. These will be the processes. If you're following the PGS, then we're really looking at process, people, finances, etc. So one, strategic investment in HRH. I'm hearing this even from the tuberculosis program talked about by Dr. Grafin, but this is happening for everyone. We need strategic investments. Two, increased competence in network and multi-purpose HRH ways of working, accountable governance, systems management, informed policy development, and collaborative decision-making platforms among HRH and the primary agencies and with the private sector. Finally, a stronger HRH, and I'm talking HRH network, and the HCPN. Partnership building, not only here, but even across stakeholders, so that the engagement and advocacy, both of public and private sectors, will actually drive HRH reform and the HRH-MP agenda. Next slide, please. I'm now presenting to you the slide for the 10 years, and the 10 years will just be 2030. I am just rolling down from what you saw to show you at the bottom part so it is staying true to what I have showed you. It doesn't change. But I think in the next 10 years, what will be important, I hope less than 10 years, will be the strategic interventions, or the PAPs. Those in government will be familiar with the program, activities, and projects, or what I call the strategic interventions. This is the HRHN, looking at the network as the startup collaborative body, as the initial cadre that could be built to advance the HRH-MP. Then we need to strengthen the network, not only in a technical way, but also in institutionalizing and strengthening so that it really becomes the fulcrum for advocacy, for promotion, and for model building. That will provide oversight, direction, technical assistance, and all the backroom work necessary for other stakeholders to move. Second is the health science education policy guidelines and legislation. There's lots of policy work that needs to be done to help the link between the education sector and the health sector so that we can produce the needed number and quality of health workers and health professionals in the country. Third is the HRH welfare and career development. There is so much discrepancy and gap between the public and the private sector, and even within the private sector. And it is not easy that our country is being, the health providers are more than half coming from the public sector. So it cannot only be government working on this welfare and career development. Next is the localization and institutionalization. Knowing the challenges of our the devolution in the localization code, we need to be able to strengthen the link between the local and the national, and therefore there has to be a mindful, empathetic, and very deliberate approach to making sure that our local partners are able to embrace, understand, and even contribute and run away with this HRHMP. Second to the last is HRH migration, management reintegration, and reservist program. It cannot happen that the whole, the creme de la creme of our products of HRH professionals are then forced, and I underline forced, to go out of the country to find a situation, a work environment that's more decent and more deserving of the investments they have done by, with not only financially, but the time and the effort to be good at what they're doing. And I think the DOH and everyone is saying that we need to address from the migration management point of view, not only that they are discouraged or even attracted to go out and attracted to stay here, but even if they have to go out, that they will be attracted to come back, because we have management reintegration programs that would make them come back. Another one is the reservist program. During pandemics, we found that it is important, like the military, to have a reservist force that can be called and be mobilized to help augment the health workforce. And finally, data. And it's not only just generating data, it is governing data and an information management system that is integrated, and which systems, IT system to IT system can actually talk, so that there is real decision support necessary to bring the country to where it is and to serve the people who needs to be served. Next slide, please. At the end of it, what are we just actually saying? There has been a whole batch of activities already identified under each strategy, under each key result area. For the HRH and strengthening, we have all the, we have the idea of HRH mandate being strengthened, the structure, the operations and accountability framework. More than anything, what we are emphasizing is stronger stakeholder engagement and advocacy from day one. No master plan will happen if the whole stakeholders, if the primary agencies are not convinced that this is going to be urgent and important. And therefore, we need continuing conversation to understand each other and help each other do the work. Capability building and team building will be important, because there are new avenues to be understood better. The whole use of technology in providing for all the consultations through telemedicine. There are the robotics, the AI is necessary. And the whole idea of a network approach under UHC for primary care provision will necessitate a lot of partnership work that goes beyond the technical and the mandated functions of each. Membership expansion is important. As it stands, HRHN can really gain a lot from active participation of the private sector, the academia involved. On the health science policy, I'll just name a few. Targeted admission, regulation in HRH production and employment, reorientation of the entire curriculum to focus a little bit more on primary health care, incentivizing all these education institutions on welfare, career and development, rationalizing the HWs and BNS, enhancing the scopes of practice, competitive benefits, career development, occupational safety and health for HRH, and performance management. On the localization, the financing and investment plan will be important for our local partners. The whole establishment of local networks will be another. The legislative agenda will be important to be shared on the local, not only the national level. The outcome-based performance assessment to be shared between the local and national agencies and the LGUs, capacity building for one, and policy framework. On the migration, management reintegration, policy studies, feasibility studies for both the migration management and reservist program has been identified. Finally, on data governance and information management, capacity building on data science and analytics. DAP is running a whole run and offering scholarship on data science, and this is very, very important. Not only data science per se, but also data analytics, data governance, and knowledge management. We need not only capacity building, we need systems to make this work so that those who have been trained have a very concrete mechanism and scaffolding to work on. And finally, the synchronization, integration of platforms. Now, having said this, you will see that all of these are actually strategic activities. But again, activities, systems, policies, financing can all be there. But without the warm bodies, the competent minds, and the committed hearts, we cannot do much. In my conclusion and closing, may I share my personal appeal? There is not much that's new with all what I have said and laid out before you. Most, if not all of these, have been clearly and emphatically detailed in the Global Strategy on Human Resources for Health Workforce 2030. Its vision, its objectives, policy options, global milestones for 2020 and 2030, including the call for progressive implementation of the National Health Workforce Accounts to support national policy and planning. We have to note that there are emerging political consensus on all this and the importance of healthcare workers to improve health outcomes. Not only that, but the proof that health outcomes and health, the HRH, the workforce, has a very close link to economic growth. And therefore, what is important to understand that if we want our economy to improve, health workforce investment and mindful and decisive action to address the urgent and important needs of the country's health workforce is imperative. Why? Because this is a sure and valuable way towards achieving inclusive prosperity and well-being for all. I guess none of you will deny that today, in this very instance, the caliber, that is the character and competence of the Filipino health professional and health workers, like many of you, has been proven to be a force to reckon with in the current COVID response worldwide. Kudos to the Filipino health professional. Bow to the Filipino health workers. Maraming salamat po.
Thank you, Dr. Garfin. I think that a key takeaway of Dr. Garfin's realistic but inspiring presentation, that no policy, no technology, no financing plans will work without the warm bodies. I think Dr. Medel is very clear in her challenge that we should go beyond our flat noses as Filipinos. I think it's very important to make bold plans, long-term plans. I think in the next presentation by Dr. Liwanag, that is what he's going to discuss in his study entitled HRH Protections and Support of the National Health Human Resources Master Plan. Welcome to the forum, Dr. Liwanag.
Thank you, Michelle, for the kind introduction, and it is my honor to be presenting before our about 700 participants via webinar jam, and to join you for the NHRFA 2020. I am honored to share the session with Dr. Garfin, Professor Medel before me, and of course Dr. Albert Rojas, our reactor for today. So my presentation will complement what Professor Medel just presented. Professor Medel talked about the overall strategic framework for health human resource as part of the National Health Human Resource Master Plan, which is actually articulated in the UHC law. And next slide, please. My presentation now will focus on the projections that we did for this master plan. I did this under the DOST Balik Scientist program, and I've been fortunate to have been hosted by the Health Human Resource Development Bureau. In a special way, I'd like to greet them now, and I'm sure they're listening. And for those of you who are not aware, we do have a Balik Scientist program managed by the Department of Science and Technology. And the program allows Filipinos who are based abroad to come back to the country and help in our country's development. For this particular one, I was honored to have been hosted by the Health Human Resource Development Bureau. And one of our engagements involved making projections for the supply and demand for human resources for health. Next slide, please. So perhaps the question that has to be asked, how do we know how much human resources for health we require? And I guess many of you are already familiar with the ratios. So that's one approach, HRH to population ratios, where we set a ratio per, in this case, for example, 10,000 of the population, and then try to see if our current supply of HRH is able to meet that ratio. So for instance, if we set it at 44.5 health workers per 10,000, and then we make an accounting of our supply, and roughly that gives us an idea if we have adequate HRH. Now, of course, this approach has its pros and cons. The advantage should be is that it's simple and relatively least amount of data required. No? On the other hand, of course, this approach has also been criticized because it is often unresponsive to specific health needs, and sometimes the ratios do not really capture the health need of the population. But nevertheless, that's not to say that using HRH to population ratios is not useful for policy development. Can you click? The other approach would be what we call service utilization approach. And under this approach, we examine current service utilization patterns, as our approximation of demand. And based on that utilization pattern, we try to forecast how much more is needed in the coming years. Again, this is simple, right? Assuming we have the data with us, assuming we have complete data regarding utilization patterns. And on the other hand, one criticism is that we can say that current utilization is not necessarily met demand. Okay, so that is probably one limitation of this approach. Click, please. A third approach would be what we would call a health needs or demand approach. And for this particular one, we look at social demographics. We incorporate epidemiological data as a way to estimate the need of the population when it comes to health services. So the advantage is that it provides a good basis for need. On the other hand, maybe a disadvantage is that we will require the use of accurate data, for example, burden of disease data, if these are available. Okay, and click please. A fourth approach is what we call WISN, and perhaps those of you not familiar can just Google. It means workload indicators for staffing needs. And what do we do under WISN? We actually visit health facilities and examine the workload of that facility. So we trace the different services being delivered, for example, in an RHU, and try to see how many hours are devoted by the doctors there and the nurses there. And at the end of the day, we get a calculation, and the number will give us an idea of the workload pressure for that particular facility. This has been endorsed, in fact, by the World Health Organization. What are the pros and cons? Well, you can imagine that this will provide a strong basis for assessing the needs for HRH at the level of the facility. On the other hand, it can also be quite complex, and time-consuming, because that means you will have to visit the facility and really examine the workload pressure there, and it will also require a comprehensive review of the records, assuming that the records are available, so that you end up with a good output for WISN, or workload indicators for staffing need. Generally, these are the four approaches to assess HRH requirements, but there is, in fact, if you wish, a fifth approach. What is that? Can you click, please? We can also just do no planning. In other words, we leave it to the market forces and let the market determine how much health workers we will produce, whether they leave the country or not, so it's up to the market. And well, this is an option, but I think if we choose to go this route, we will be irresponsible in our mandate. And let me echo what Professor Medel also said, that no planning is like, being blind. So I think, well, it's a choice, but this is something that we should not do. Click. So we have a range of approaches, no? And well, you have an arrow there. As we go towards the side of the ratios, these are the more simple approaches, no? They require less data, but at the same time, they are usually the more crude estimates. But nevertheless, they're still useful. I'm not saying that we cannot use them. On the other hand, if we go to the other side of this spectrum, towards the side of Quizzin, then these are the approaches that are generally more complex. However, they're more time consuming, but at the same time, they will be able to give us more accurate projections. Click. Let me just say that for our technical assistance to HHRDB, we deployed the use of ratios, and also we used the health needs or demand approach by looking at the burden of disease data. And at the same time, Quizzin has been piloted by the Bureau. Okay, but for today, I will only present what we got from the ratios and what we got from the health needs or demand approach. Next slide. This is the overall methodology. So on the left, you see there the ratio-based approach. How did we do that? Well, we obtained a comprehensive data set from the Professional Regulation Commission under the assumption that the valid licenses, the count of valid licenses would approximate our count of available HRH, in terms of supply. And we aim to project the future supply of HRH using the Leslie projection model, which you can also Google. But essentially, the assumption under the Leslie projection model is that entry and exit into the system is rather stable through time. And so under this approach, looking at the trends in previous years and using census data of 2010 and 2015, we try to project how much more health workers we will produce for the next 50 years. No? And then once we know the supply, then we estimate the demand based on the ratio, because the ratio is our approximation of demand. On the other hand, we try to complement that approach with the health needs approach, and in this case, working hand in hand with the same team that worked with the Health Facilities Development Bureau for the Philippine Health Facility Development Plan. Now, in this case, we use the same data set to generate projections that will take into consideration population growth at national and local levels, the burden of disease data also at national and local levels, as well as other relevant factors such as level of secondary education and the LGU income per capita of that locality. So the team did this in a multiple regression, and then we were able to come up with national level and local level projections for demand. Okay, next slide. So I'm happy to report that we are making projections for 10 health professions, I think, which is the first time that it's been done. And they were selected because of their relevance for primary care. So nurses, physicians, midwives, dentists, medtechs, radtechs, pharmacists, nutritionists, dietitians, physical therapists, and occupational therapists. But I will not be presenting all of them today due to time constraints. Next slide. So as I said, it's the first time, I think, to undertake projections for the 10 health professions. And we are doing not just ratio-based projections, but we are trying to complement that with a demand-based approach. And at the same time, we have national level projections, which we try to complement with local level projections. So initially at regional, then provincial and city levels, consistent with the direction towards integration of province-wide and city-wide health systems. Next slide. So let me just show you, for example, our number of nurses in terms of supply. So this is the supply of licensed nurses in the Philippines since 2010. And you see here for every year, the green being the current supply, and then the blue telling you the number of new nurses per year. Why is there a whiteboard being shown? Okay. So you notice here that way back in 2010, there were about 73,000 newly licensed nurses. That's a lot. But as of last year, 2019, that has gone down to 11,000. So we were producing so many nurses 10 years ago, but that has somewhat tapered a bit in recent years. And if you look at the ratio per 10,000 of the population, it's still high. As of last year, it would have been 46.2 per 10,000, but that has already gone down from, for example, a high of 58 between 2014 and 2015. Next slide. Let's look at the physicians. So again, the blue bars represent the number of new doctors per year. And as you can see here, the production of physicians per year has been relatively stable. Although last year we produced more than 5,000. That's more than twice of the new doctors we produced way back in 2010, which was only 2,000. If we look at the ratio per 10,000 population, the ratio is rather stable. It's hovering between 7 and 8 for physicians. 7 to 8 physicians per 10,000 population. Next slide. And now let us look at the midwives. What does this graph suggest? We do notice a slight reduction in the production of midwives, especially in recent years. The ratio also is slightly going down from what used to be 9.4 in 2010 down to 6 or 7 recently. So this is perhaps something we can look into. Why is production of midwives going down? Next slide. So overall, if we combine the 10 health professions, we do note that we have about 854,000 of these 10 health professionals with valid licenses, majority of which, almost 60%, are the nurses, followed by physicians, midwives, pharmacists, and so on and so forth, as you see on this slide. Next. Next slide. Next slide. Can we go to the next slide? Or I'll do it. Okay, I'll do it. Okay. So this slide now shows you so we have 10 health professions, and these are the top 5 health professions with the highest ratios per 10,000 population. So as expected, we have the nurses having the highest ratios, although as I said, there has been a slight reduction in the production of nurses in recent years. Nevertheless, they still have the highest ratios. You look at the physicians, just stable, slightly increasing. The midwives, as we've noted, is slightly decreasing. And we have a slight increase in the ratios for medtechs and pharmacists. Next slide. Okay, I'll do it. And these are the next health professions with the lowest ratios. We've noticed that for dentists, the ratio is rather stable. We have an increase in ratios for rad techs. For physical therapists and nutritionists, dietitians, the ratio is rather stable. Very slight increase for occupational therapists. In fact, the occupational therapists have the lowest ratio to population among the 10. Now, the question is, how do we know if we have enough health workers given that supply? And so if we look at the ratio, the WHO recommends, particularly to achieve universal health care, that we should aim for a ratio of 44.5 per 10,000 population. And that's 44.5 skilled health workers, meaning we combine nurses, physicians, and midwives. If we do that for the Philippines, we will in fact get 67.9 per 10,000, combining nurses, physicians, and midwives. That means we in fact exceeded the ratio, right? If this is correct. So that means we don't have a problem anymore if we are in fact exceeding 44.5 because we have 67.9. So I guess we have to dissect this further to know more about the data. So if we zoom into the specific health professional, because as I said, it's 44.5, but what is the share of the nurses in that 44.5? And WHO says it's 27.4. So for nurses, clearly, we still have an excess. It's at 52. Now, when we look at the physicians, here we see that there is it's lower than the desired ratio of 14.3. So in this time we get 8.1. So we have a very low ratio for physicians alone. And if we look at the midwives, we slightly exceed also the ratio for midwives. So the suggestion is 2.8, but we have in fact at national level the ratio of 7.8 for midwives. It, of course, becomes a different story when we try to localize the ratios. So what we've seen in the previous slides are the national level ratios. What if we look at specific regions? No? For example, physicians in NCR. So again, for physicians, the desired ratio is 14.3. But if we look at physicians only, we get 26.5. Clearly, this is well and above the minimum ratio suggested for physicians. But if we look at Mimaropa only, again, target for physicians, 14.3. But here in Mimaropa, we only have 1.7. Very, very far from the target. And so this is where you see inequity. The ratios vary when you try to look at localities. So based on those findings, we make the following suggestions and observations. So increasing ratios for medtechs, radtechs, pharmacists, nutritionists, dietitians, and occupational therapists, but noting nevertheless that for OTs, they still have the lowest ratio at only 1.12 per 50,000 population. There is a stable ratio for physicians and physical therapists, but at national level, physician ratios are still below the threshold for UHC. And we've noted decreasing ratios for nurses, midwives, and dentists. At the same time, saying that even if nurse ratios may be decreasing, their numbers are still above the threshold for UHC. Initial recommendations at this stage, given the data that we have. Well, for scholarships, perhaps we can prioritize those health professions, which the ratios indicate to be in low supply. So that would be physicians, midwives, dentists, and occupational therapists. And if we do have an excess of nurses compared to the physicians, then perhaps we can strengthen stepladder programs so that nurses can then become physicians and they become added to the supply of physicians. And supporting the HRH needs of provinces with the low ratios. And at the same time, recommendations to explore this concept of task shifting. So if you have more nurses compared to physicians and midwives, then perhaps the other health professional can be credentialed to take on some of those functions. Okay, but that will require, of course, adequate training for them to be able to do that, and of course, a credentialing program, and at the same time providing the legal framework to make that possible. Now, I've only shown you the supply and an approximation of demand based on the ratio. So let me show this to you. So this is our projection for physicians for every 5 years until 2050. So there you see. So if our projections of supply are correct, then we will expect a steady increase in the production of physicians in this country. But it will never meet the target density of 14.3. It will only go as high as 10.5 according to our projections. Because that means if we want to meet 14.3, we would have produced 65,000 plus physicians by 2025 alone, based on our arithmetic. And clearly, this is an unrealistic goal. We will never be able to produce 65,800 doctors in 5 years, okay, just to meet that ratio. So this is the part where I'd like to say that the ratios can be a guide, but sometimes they don't really, as I stated already, give a comprehensive suggestion, okay, on what we can do in terms of policy. So this is where then we will incorporate the projections based on burden of disease. And looking at the top 23 diseases, in the Philippines based on BOD or burden of disease data. So we incorporated these into our modeling, and then we came up with a calculator which we have endorsed to HHRDB. So if we know that those are the top 23 diseases, oh, by the way, I have to say that we have not yet factored in COVID, because we have yet to see the calculation of the burden of disease related to COVID. But nevertheless, based on those diseases, then we have a calculator where we put in how many hours a professional will have to give at the level of primary care. I have to say that we are first doing this only for primary care because that is the priority in UHC, right? So, and then make calculations based on if this is the number of hours allocated for health services, and given these diseases, then how many hours are required for physicians, for nurses, for midwives, and for the other health professions. So we have that calculator. And if you use that calculator, for example, for the Philippines, if our calculations are correct, based on the top 23 burden of disease, then by 2025, we will need about 30,000 physicians at the level of primary care. Okay, let me emphasize that this is for primary care. Clearly, if you compare that to just using the ratios, it's quite different this time. And our supply, projected supply, total supply of physicians by 2025 is 102,000 plus physicians. And that's the total number of physicians. So that means that by 2025, if we want to meet the required demand at primary care level, 30,000 or so of that 100,000 doctors should be doing primary care. So they should be dedicated for primary care. And the calculator also allows us to make estimates for this at the level of cities. For example, this shows you estimates for Davao City for the 10 health professions starting at 2025 onwards. And also, for example, I picked Palawan. So this, for example, gives you the estimate for Palawan. So let me conclude at this point. I have the following key takeaways. First, we are in the process of completing the National Health Human Resource Master Plan. Professor Medel gave us the overall strategic framework for that. And an effective HRH master plan will require being able to project future supply and demand of human resources for health. Second, I have to say that there is no perfect approach to make projections for HRH supply and demand. In this particular endeavor, we chose to do two approaches, okay? But we have to choose an approach based on the data available, but at the same time, recognizing the limitations. And no planning at all is not an option for us, okay? We have to do something, we have to make projections. Projections are not a one-time endeavor. It will have to be regularly updated. So the projections I presented today most likely will no longer be accurate next year, especially because of COVID. And so ideally we do projections every 5 years. So this should be a regular undertaking, but it doesn't also stop us from making projections 50 years from now. So we try to project until 2045 or 2050. But that doesn't mean that the next projection will only be in 2050. Okay, we will have to update the projection, say next year or in 5 years. And finally, for these particular projections, we estimated future HRH supply and future demand for HRH, again, prioritizing at the level of primary care. Efforts are underway to get a more complete picture of the number of primary care practitioners. So I presented some numbers for primary care, and there are efforts right now to establish our national registry, and perhaps that will also allow us to have an accurate count of the number of primary care practitioners. because that will also be our guide in in making sure that we use the projections for strengthening primary care practice in the Philippines to accelerate universal healthcare. Let me just acknowledge this is not just my work, but I have been fortunate to work closely with the folks in HHRDB, as you see on the screen, and also our colleagues from the Philippine Institute for Development Studies. So thank you very much for this opportunity to present for NHRFA, and we welcome your suggestions and comments.
Okay, thank you, Dr. Liwanag. I concur with your statement that data will change from time to time, but it will never change the fact as well that data will make us will help us to make evidence-informed policy development that will help us achieve the ambition for all Filipinos, the universal healthcare. Thank you for the comprehensive and extensive presentations, Dr. Liwanag and Dr. Gregoria Medel. I think those presentations are very inspiring. I would like to emphasize as well, plannings make us more hopeful for the future. We will now open the floor for the reactor, Dr. Alberto Rojas. To introduce our reactor, Dr. Alberto Rojas is currently a consultant to the DOH and a technical panel of health professions education chair to the Commission on Higher Education. From 1984 to 2015, he served as a professor and a dean in the UP College of Medicine. Welcome to the forum, Dr. Rojas.
Hello, a pleasant good afternoon to everybody. I thank the organizers for inviting me to participate in this session. It's an honor to be here. And I have a disclosure to make. I am the chair of the technical panel for health professions education, but I have the written authority from the Commission on Higher Education to make statements. So that means what you will hear from me are entirely my own. And my reactions for the first paper given by Dr. Professor Medel, it's an excellent presentation, very candid, and it's almost overwhelming. We have so many problems, but just like like any other Filipinos in this country, we are so accustomed to having so many problems that we just try to do the best we can at small steps at a time, and hopefully we will be able to achieve maybe in a generation or two what the plans calls for. But the plan that was presented to me is very good. And the COVID pandemic has actually exacerbated all the deficiencies of our system, our lack of human HRH, health workforce, and our fragmented health systems. I don't have to elaborate further. She gave a very passionate and comprehensive presentation on what our plan should be, 10-year, 20-year. So with those, we can follow that as a framework. But, we are just nibbling at these problems. I guess the thing to do is really try to get together and try to solve our problems little by little. We have so many silos that we cannot think at the big picture. And that is sad. And we always lack funding to do things. And that should be the right way, with funding and with the plan. That should be the way to go. Unfortunately, with COVID pandemic, there are other priorities, and I accept that these priorities has to be taken care of. But what we can do is we can slowly work on this networking and partnership that is required. It's really difficult to work wherein you need the other agencies of government and private sector to come together and try to solve all the problems that we have in order that we can have a working HRH master plan. The strategies that has been presented are, I think will become very useful for us. And I like to think that I am hoping, and maybe we have the optimism that by the year 2040, Filipinos are healthier through improved health outcomes and responsive health system performance. So just two things, but the challenges are so much. But let's not be overwhelmed by such challenges. Let's just continue to work the best way we can, and hopefully we can, the great journey starts with the small steps, like-minded people coming together, working together, and maybe little by little we should be able to make our way towards the plan. But I guess it is important that it is a recognition that we should have these plans guiding us along the way. On the second presentation by Dr. Liwanag, it was a very informative presentation. He gave a good overview of estimating health workforce requirements and discussed the methods used in projecting the supply and demand for 10 selected health professionals in the country. Yes, it is true. This is the first time that we have projections for the 10 health professionals. Usually it's only the physicians, the nurses, or the midwives. But I guess the universal healthcare wants to find out how things are in terms with these 10 professionals that are needed for the primary care, the first aspect that we have to implement in the universal health care. And again, I agree with the presenter, Dr. Liwanag, that we should have a plan. It will be definitely useful to guide all of us. And at the moment, what do we do? We rely on no plans at all, and we just listen to what the news items tells us. And if there are calls for recruitment abroad, you will notice that the next thing you know, there will be more schools sprouting out. This is exactly what happened many years ago when the flavor of the month was the nurses, and all of a sudden, from 150 nursing school or 300 nursing school, it became over 700 or so. And now it has gone back to about 300 plus. So market forces, that's how we are in the Philippines. Laissez-faire, matira matibay. But, that is not the best. I think we need to find, we have been market forces, dependent on market forces for the longest time. I think it's about time we should now start using plans, the projections to help us guide ourselves in producing doctors and the other health professionals. You will also notice that the maldistribution of health professionals contributes to the problem. We are an archipelago, and most of our health professionals will gravitate to urban cities. And this is understandable because these are the places that can support their livelihood. So in areas where there are none, the economy is so poor, like, the other regions, the poor regions of the country, I guess it is left to government to provide the manpower and improve the health systems that it can effectively deliver the health the delivery system that the people will need. So I guess there is still so much to be done in our country. But studies like this will sometimes remind us of the things that we need to do, and we should not give up, because the Filipino is always worth dying for, and we should continue the best way we can in order to reach our goals. Now, when we will reach our goals, when we can have or achieve or implement universal healthcare, your guess is as good as mine. With COVID pandemic, it's really a big problem. But it should not dissuade us from pursuing what needs to be done. Thank you and good afternoon.
Thank you, Dr. Rojas, for another set of inspiring messages for the people, for the participants listening us today. I think po, if I'm going to summarize your statements from Dr. Gregoria Medel until your statements po, I think I've reached 4 P's. There should be planning, there should be projections, and there must be committed, passionate people. And I think that's it. Passionate people. I have now 4
And don't give up the ship.
Yes, po. We're not jumping off from the ship. Thank you. Thank you so much for Dr. Rojas.
Welcome.
Okay, we will proceed now to the Q&A portion of the program. Just like we mentioned earlier, we have collated the questions raised or typed in the chat box. May I request Dr. Luwanag and Dr. Gregoria Medel to prepare to turn your camera on. Okay, for Dr. Gregoria Medel, I have 4 interesting questions po. The first question is, this is from Mr. Ernesto Gregorio po. Question is, how do you connect to the HRH plan of the local governments when they are autonomous? We should have something more than the deployment program for the LGUs.
Okay, should I respond now?
Yes, po, ma'am.
Okay. This, I must admit, is a very difficult question, because precisely it is not only that they're autonomous, it is actually there's a law that has already been in place for decades, the devolution or localization, the local code. And we know very well that this is something that has been shown to be quite a challenge for us to bridge. This is why it's very important that not only is the DOH the only one spearheading this actively, we really will need to bring on board the DILG, even the local government associations or federations, the provincial, the provincial as well as the local, the mayors league, because it is not a question of just doing the technical aspect of it. There is some fundamental changes that has to happen. It might even be some basic improvements in existing legislative parameters in how we will have to approach this. But think about this. This is the best time for us to think again about what needs to be done. It might not be anymore a question of autonomy. It's a question of how are we going to deliver the reform to our people and how to make sure that our people are healthy. I must admit, Mr. Gregorio, that we need to address the whole autonomous mandate of the local government, and therefore, even at the very early stage of the master planning, we have already the DILG and the HRHN, very close coordination with several champions of health from the local government, LCEs and the governors, and we are now really advocating that a very participatory, collaborative operational planning happen so that the local government themselves can already embrace the agenda and pave the way for their own active engagement in this aspect. Salamat po.
Okay. I hope for the participant who raised the question, Dr. Gregorio Medel is able to answer the question. Here is the second question po. In addressing the insufficient number of HRH in the country, which aspect do you think should government focus more on? Education and production, or welfare and retention? This is in consideration of the fact that Philippines is one of the top countries who exports its HRH.
Yeah. Again, let me just first share with you, when I was with government, with the Department of Social Welfare Development as Undersecretary, one of the things we understood, especially when we faced Haiyan, it's also like a COVID in many ways because it's unprecedented, the first ever in the world, such kind of a weather disturbance and disaster. What we realize is we have to reform while we perform. And the whole metaphor is like, the jeepney, the Philippine jeepney that's, rattling, down the road. We know that there's so many things to improve on the jeepney, the smoke belching, whatever it is, we need to improve on it. But one of the things we cannot do is to stop running that jeepney just so we can do all the necessary improvements. We have to run that jeepney even while we're improving on it, because we have a purpose, we have service, we have to deliver the people, the passengers, to a destination called health. I have background noise. Okay. So my short answer here is that yes, we need to do both. I think what we need to do is to buckle down to the situation of each stakeholder and find out which of this will be in the better position, which is the low-hanging fruit. I'm not saying there's a priority. We have to do both. That is very clear. But I think what is urgently important is to understand, for each stakeholder to address the situation, you look at where you are, build on what you've got, and do what you've got to do. And I'm going to underline what our reactor just said, Dr. Luan, is that we need to do what we need to do and do it now. The little thing that we can do will go a long way. Salamat.
Okay. Dr. Gregorio Medel, there's another question po. I hope you would still want to answer this question. This is question po from Mr. Miguel Manuel Dorotan.
Yes.
The question is, yes po. The question is, what is the strategy on surge capacity as part of resilient health system? We always have this challenge during emergencies and disasters.
Okay. What is the strategy on surge capacity as part of the resilient health system? I think, Migs, this is where I thought one of the things that came out in the consultation, the reservist program, will really help. If you're familiar with the military setup where we have reservists, whether from the retired or from even those who had special training, who are not directly military trained, but would already be given orientation so that they step up during the times when there's a need for surge capacity, will be a very important thing to really study closely and even to pilot. This is where I thought many of those who have retired, many of those who are balikbayan, many of those who were graduates of HSE but did not get to be licensed or did not get to practice can still use their old training and some of their experience. I would like to also include in the reservist program our traditional healers, and all the Filipino is imbued with a natural caring DNA, they tell me. And I think this is one of the things by which we can augment the frontline and the health workers during this pandemic. Look, this is a pandemic. Nobody really could say what a pandemic really means. What we can do is learn from our experience now and from the past, and really try to find out what can be improved. But if it's HRH we're talking about, we really need, as I said, a reserve program and a system to really deploy and mobilize them and continue their, their training so they're ready at any time, at any call. Salamat.
Okay. Doc, there's another question po. Thank you for answering that question. Question number 4 po is from Ms. Aurora Parong. The question is, how are leaders within the health system appropriate for the highlighted areas that need improvement? Such issues highlighted like governance and accountability, UHC, and HRH.
Well, Ms. Parong, and this is where I must admit that I think what is really needed at this point is to really come to actionable consensus. There are so many things demanding our attention and our efforts. We can feel lost and confused because there are really a million things, and just on the HRHMP, as already shown, scope, the magnitude, the breadth and depth of the work is so systemic, so macro and micro at the same time, that we really need to make a serious effort to really look at what is it that we're willing to do. I don't think it's really what we can do, but we're willing to do, and that would really mean what kind of investments are we willing to do, because we cannot have the budget necessary for everything. We need to prioritize, and decision making is important. And I'll go back that decision making has got to be based on some data analytics. Not that data is always the truth. The truth can actually mean many things, but at least data can help balance our own perspective, our own biases, and point us to where we need to go in a more hopefully objective, to balance our intuitive and emotional predispositions as a people. And I say that then the only way we can attend to governance and leadership, to accountability, to care, health, HRH care and all, and data governance is to be able to agree on it, and not only to agree on it by paper, but to really actively engage in it and do it now, not in 2040.
Okay. Thank you for that comprehensive explanation, Dr. Garfin. We will move on to the presentation of Dr. Liwanag. We will be entertaining 5 questions for Dr. Liwanag. The first question is, this question po is from Ms. Annabel Arceo Rebolido. The question is, will it be possible for the Balik Scientist program to consider recruiting the population of retired scientists to be able to utilize their wealth of experience and expansive worldviews?
Well, thank you, Michelle, for being the moderator, and thank you for that question. Before I answer that question, let me just pick on what Dr. Rojas said about doing small steps and starting with little things. I agree. I really appreciated that comment from Dr. Rojas. Sometimes our problems are so huge that we get overwhelmed, but if we think of them as little steps, then perhaps one by one we can solve our problems. And of course, we have to surround ourselves with like-minded people. And I'm happy that we have someone like Dr. Rojas, someone like Professor Medel to be part of this circle. Now, just to answer the question, thank you for that question. Yes, the DOST Balik Scientist, by all means, allows even retired Filipino scientists who are based abroad to come back to the country and help in our country's development. So for anybody who's interested, or if you know anybody whom you can recruit, please get in touch with them and just visit the website of the DOST Balik Scientist. There is a special website dedicated for it, and the application process and the documentary requirements are all explained there.
Okay, thank you, Dr. Liwanag. Are you still there, Dr. Liwanag?
Yes, I'm still here.
Okay, thank you for that. The next question po is from Mr. Welby Biligano. The question is, do we have a standard guidelines that will serve as reference regarding patient ratio to achieve the quality care which is applicable for both public and private hospitals here in the Philippines?
Thank you for that question. If he is referring to health worker to population ratio, then in that area there are recommendations like the 44.5, no, per 10,000, which is a recommendation from WHO in the context of accelerating universal health care. But as I said, and as you've seen in the presentation, ratios cannot also be absolute. So we always have to interpret them with a grain of salt. As to the ratio specific to facilities, I understand that in DOH, for example, our regulation team or our health facilities team have defined the standards for that. And I cannot tell you now, but you can refer to the requirements for licensing and accreditation, because the ratios there are indicated. And the assumption is that if you meet that ratio, then you're supposed to provide quality health service. But of course, that is not always the case, because I have to say that the number of health workers is not the absolute requirement to deliver quality health service. You also have to make sure that they are competent, they are motivated, they are well compensated, they are happy about the job that they're doing. So even if you meet the ratio, but they're not competent, then it doesn't deliver quality health service. We have to understand the whole thing with a complex way of thinking, the context of systems thinking and health system strengthening.
Okay. Thank you for your answer, Doc. There's another question po. This is from Ms. Lizelle Lagrada Romboa. The question is, if the projected HRH would imply integration of health workforce across LGUs, how would this impact on hiring of HRH by individual LGU?
Thank you, ma'am, for the question. I think I know ma'am, if I heard the name correctly. I don't know. I don't have the answer to that. Unfortunately, the competent authority to answer that question would be, I guess, DOH. And we have to think of that in the whole context of moving towards integrated province-wide and city-wide health systems. And then you have the special health fund. So it goes back to the very comprehensive universal health care law. And I trust that our colleagues in FICTI, in BLHSD, and I think are working on that and trying to understand how to operationalize it.
Okay. Thank you, Dr. Luwanag. One last question po. This is from Mr. Juan Maria Pablo Nanagas. The question is, what will the impact of ASEAN harmonization in our HRH concern?
I think I lost the video because my connection is slow, but I heard the question. Can you still hear me?
Yes, loud and clear.
Yeah, all right. Thank you for that question. I think the ASEAN integration provides an excellent opportunity to really enable our health workers across ASEAN to also practice in other countries, no? But at the same time, there are many other considerations that have to be looked into. So I don't have a straight answer to that difficult question, but it's not easy to operationalize it. Imagine, for example, if I'm a Filipino doctor and I believe that ASEAN integration will, for example, allow me to practice in Thailand, but I don't speak the Thai language. So that's another complicated thing, right? So I think ASEAN integration is something that provides a good opportunity to perhaps collaborate with our ASEAN neighbors, but as to how it will exactly solve our HRH inadequacies is still something to be examined. But I will rather see it as an opportunity rather than a threat.
Okay. Thank you, Doctor. I think there's a very interesting question from Miss Annabel Arceo Rebollido. She said, because of the double burden of diseases in the Philippines, many physicians, nurses choose to go to specialty training. Perhaps what can be done to support The HRH requirements for UHC is to encourage the available healthcare contingency to stay competent in the practices of general medicine as well as those of their specialties or subspecialties.
Thank you for that comment. I agree 100% with what she said. And this has to do with competence. And even if at the moment we have some problems, no, I am optimistic about the future because there are many things happening. And for example, there is now a pending bill regarding nurse certification, if I'm not mistaken, so that we will have nurses who can then qualify to be accredited as, I forget the term, but I think nurse specialists or something like that. So this is part of the whole context of equipping our health workers with the right amount of competency so that they can serve our people well and so that we can achieve universal health care. And I'd like to go back to that slide about task shifting. It's a concept. If there must be a way for certain professionals, if there's an excess of this group, to be allowed to perform selected functions for certain health professionals that are lacking. So they're doing that in other countries. So why can we not explore that as well for the Philippines?
Okay. Thank you for your enthusiasm in answering the questions of our participants. I think everybody has something
Thank
to
you.
think about. And the next days, maybe those answers could be a driving force in continuing research on HRH. Okay. Thank you for sharing your expertise, Dr. Lumanag and Dr. Gregoria Medel.
And thank you, Michelle, for the excellent moderation.
Okay, thank you for the cheer. Thank you, sir.
Salamat po. Salamat, Michelle.
Thank you po. Okay, that is the first set of our studies. I think a break is in order to have a bladder break, either to have a coffee break, but not a cigarette break. So there will be a 5-minute break for this for this session. Hindi natin ginamit ko eh. Ano, Okay, and we're back. Coming up next is the next set of presentation focusing on health facilities. I would just like to welcome the participants who just checked into the platform. The third study is titled Optimization of COVID-19 Facilities. For the third study, we will be joined by Mr. Roderick Manzo Napulan. Mr. Napulan is currently the Division Chief of the Research and Performance Management Division and the Development Bureau of DOH. He is also the project leader for the Green and Safe Healthy Facility Program of the same bureau. Mr. Napulan is the National Advisor of the Philippine Association of Health Records and Information Management Officers Incorporated. The study aims to present the current situation of COVID-19 temporary treatment and monitoring facilities, or the TTMF, vis-a-vis updated cases reported through the DOH data collect applications. He will discuss also the factors affecting COVID-19 bed utilization and referral of patients to TTMFs. He would also identify the gaps in the appropriate utilization of the facilities and propose strategies for the optimization of utilization of COVID-19 health facilities. Good afternoon and welcome to the forum, Mr. Napulan.
Hello.
Good afternoon, sir.
Good afternoon.
You're looking great, sir.
Thank you.
Okay, so without further ado, we will give now the floor to you, sir.
Thank you. Good afternoon, everyone. And thank you for the organizer of this event for allowing us to share our policy research initiative on the optimization of the health facilities utilization. So before I'll continue, let me recognize and thanks my policy research team headed by our director, our bureau director, Maria Teresa G. Vera, Mr. Erickson A. Feliciano, and Ms. Diane Melody A. De Rojas. Special thanks also for my team in the division, the Health Facility Development Bureau, Research and Performance Management Division, and to all the staff of the HFDB. So this policy research was in response to the overwhelming health facility capacity last June 2020, wherein we observed an increasing number of COVID-19 cases and overwhelming bed occupancy of the TTMF as well as the DOH, as well as the hospitals. So the study was submitted to the Health Facilities and Infrastructure team, headed by our Undersecretary for Health, Lilibet C. David, and the recommendations were submitted to the Secretary of Health for policy action. For the objectives of this study are the following: so to analyze the situation of the COVID-19 TTMF, or also known as the COVID-19 Temporary Treatment and Monitoring Facilities, vis-a-vis the updated cases reported through the DOH and data collect app. Then we identify the factors affecting the COVID-19 bed utilization and the referral of patients to the TTMF. And we identify gaps in the appropriate utilization of health facilities, and strategies were proposed to optimize the utilization. So the Department of Health last April 11, 2020, issued out the Department Memorandum Number 2020-0178. So in this policy, we identify the flow of patient in the delivery of services. As all we know, we should always be reported to our barangay health emergency response team, or our BERT. We have two ways to proceed to the health facilities. Either we can call through the facilities, through phone. If you have internet, then you can call the hotline of the Department of Health, or if you have access to your health facilities or to healthcare provider, you can contact them through phone calls or through emails. Then in other case, you can proceed to the primary care facility. So for the primary care facility, in your community, you have your barangay health stations, or if you are residing in the city, it's called also a barangay health centers or in city health centers, or if you are residing in the rural health, so you can proceed to the RHU. So it depends on your condition, whether you will be admitted to the hospitals or to the temporary facilities or to the lower facility of the hospital. So in this case, for us to fully maximize and optimize the resources of the government as well as the health facilities, as all we know naman po, for the COVID patients, medyo maraming PPEs po yung gagamitin for this. So dapat appropriate din po na facilities yung ating pupuntahan. So here's the diagram showing kung depende sa conditions po natin kung saan po tayo pupunta. So appropriate facility for appropriate condition of the patient. So for the severe case and critical symptoms, if you have experiencing this, so you can proceed with the COVID-19 referral hospitals or the level 2 and 3. While for the suspect probable and with the mild conditions or symptoms, you can proceed to the temporary facilities and then the level 1 and then the infirmary. While for symptomatics and or you have already a close contact with the COVID-19 positive, so you can opt to proceed to your for home quarantine kung may vacant po na space in your respective homes, or you can go to the temporary facility. So there are two types of temporary facilities and that I will discuss later on. But basically, aside from catering mild symptoms, ito rin po yung magiging step-down care facility. So from the higher level hospitals like level 2 and 3, as well as the COVID-19 referral, para ma-decongest po natin ito, so we're suggesting dapat na yung mga mild na or pagaling ng mga patient, you can proceed na po sa TTMF naman. So that we can free up the beds in our COVID-19 referral hospitals as well as the level 2 and 3. So that's the concept for the healthcare provider network. So what is TTMF? TTMF stands for the Temporary Treatment and Monitoring Facilities. So it serves as the facilities for suspect probable confirmed COVID-19 cases with mild symptoms. But always remember that the pediatrics as well as geriatric patients ay hindi po inaalaw po dito because of some vulnerabilities, and dapat without comorbidities lang po ito and may be used as the step down as mentioned kanina. So the Department of Health, so to gather more efficient and timely data for informed decision making, coming up with a system we call the Data Collect App. So the Data Collect App there are two types. We have the system for the TTMF as well as for the hospital. So the hospitals or the facilities encoded their data, daily submission po ito, so that daily din po ang reporting po natin. As you can see in your social media, in the social media card, as well as the DOH daily updates, ito po yung nakikita po natin na data in terms of utilization ng ICU beds, isolation beds, wards beds, as well as yung availability ng mga ventilators po natin. So 8 AM po yung cut-off nito, and these are provided by our health facilities. The system was developed by the Knowledge Management Information Technology Service together with our partners like the Ateneo. So for the methodology of this policy research, this mixed descriptive study, we gather data from hospitals, from the TTMFs, as well as sa mga medical center chiefs ng hospital. Then we extract the data from the bed tracker for the hospital beds, and the TTMF tracker naman po using the Data Collect App. The focus group discussion was also done so that we can generate a deeper understanding of the reasons why we gather such analysis para mabigyan po tayo ng mas clearer feedbacks coming from our hospital managers and temporary management facilities po. So sample po nito, this data was extracted last June 8, 2020. Ito po yung kasagsagan na tumataas po yung cases po natin. So in response of our bureau to gather evidences as well as to provide a policy recommendations, as shown here, nasa warning zone na po tayo. So naka-color yellow. So may tatlong thresholds po tayo dito for the data collect po natin. We have the safe zone kapag 30% and below po yung bed occupancy rate, and we have the warning zone pag nasa 70%, and then danger zone between 70 to 100%. So with this data, nakikita po natin na underutilized po yung ating mga TTMF in NCR. So this data can also provide the picture kung gaano ka importance din po ang TTMF later on. Looking into the mega TTMF, so yung mega TTMF, ito po yung mga larger spaces and facilities po ng government na converted into a temporary facilities like the Ninoy Aquino Stadium, the World Trade Centers, as well as yung Ultra Stadium. As you can also see, medyo mababa din po yung utilization as of June 8. So there are two types of TTMF. We have the COVID ward beds and as well as the isolation beds. In the previous slide kanina po, the isolation beds is 51% lang po yung kanilang utilization, while the COVID ward beds man po is 39%. The COVID ward beds for TTMF, referring to confirmed na po na cases po ito, so that we can cohort them. While for the isolation beds naman po, ito yung mga TTMF na meron tayong separators with rooms po ito. Okay, looking into each of the TTMF in Metro Manila, we can observe that some of the TTMFs are underutilized while some naman po ay underutilized. And then reasons for this later on will be discussed. So this TTMF pertains to the isolation. Isolation po ito, and then as well as for quarantine po. While these TTMF are all, makikita nyo halos lahat po nito, hotels. Kasi pag hotels, dapat may separator tayo para, kasi as mentioned na kanina, for isolation purposes, the confirmed, the suspect as well as the probable cases were mixed po dito sa may TTMF na isolation purpose, for isolation purpose. So usually these are hotels converted into facility, health facility. So we looked into the data of the hospitals and we found out that 16% of the COVID patients po natin na confirm ay asymptomatic, while 22% na probable and suspect. So anong pong ibig sabihin po nito? Ibig sabihin, if you recall in the previous na diagram I showed kanina sa healthcare provider network po natin, supposedly asymptomatic and cases ay dapat nasa TTMF or sa lower facilities. So ang nangyayari, may mga cases po tayo na asymptomatic, which means nagkakaroon tayo ng overburden sa hospital. Just to inform everyone, the cost of services for higher level facilities is much higher compared po sa mga lower facilities. Based on our study, in the separate study po ng HFDB, nasa 3,000 per bed per day po yung inpatient days po natin, ang inpatients natin na cost for level 2 and level 3. While for the level 1, nasa 2,500. So ibig sabihin, as you stay longer na hindi naman appropriate yung iyong diagnosis, lumalabas po na inefficient po tayo sa pag-utilize po ng ating mga available resources, especially in the government hospitals. Looking into the private naman po, nasa 56% or more than half po ng confirmed COVID cases admitted in private hospitals are asymptomatic, while merong 23% naman po na probable and suspect. By level naman po, we observe that 17% of the level 3 hospitals are asymptomatic, while level 2 naman is nasa 30%. What we are worrying here in these tables is that 21% of the level 1 admitted patients are with severe and critical. So meaning they may have a difficulty breathing na dapat kailangan nila ng ICU or any respirator. In our licensing po, the ICU are only required in the level 2 and level 3. So lumalabas na here in level 1, meron pang mga critical and severe cases na na-admit po sa level 1. So some of the reasons could be na kulang talaga yung available ICU beds po natin. We also observe the trends in terms of response rate na medyo mababa pa po siya. So this is one of our recommendations later on that we need to strengthen the response rate of the treatment monitoring facilities po natin. We look also on the DOH hospital submission on the Bayanihan Fund Act. We monitor the different comorbidities of the hospitals, and we found out na asymptomatic cases, although they are asymptomatic in terms of their COVID, but meron silang mga comorbidities. And most of these comorbidities ay may related din sa infection like respiratory tract infection, community-acquired pneumonia, etc. So likewise, when we look into the confirmed and suspect probable na mild, marami pa rin po tayong nakikita na related sa respiratory tract infections. Na it seems na dapat kailangan pang further study or to determine why is that hospitals have the following comorbidities for COVID patients. So we initiated and conducted a focus group discussions with the hospitals and Mega TTMF to understand the reasons for these inconsistencies with the policies as well as non-compliance to the requirements of the Department of Health. So we have here the list of hospitals who join us to provide the deeper understanding and to provide us further discussions of the reasons. So several questions were posed during the focus group discussions. So we determined the process of referral, kung bakit mababa yung referral na ginagawa, referral rate po natin. Tinignan din po natin yung referral to the TTMF. Yeah. Then the factors for inhibiting and facilitating the referral, and as well as bakit nga asymptomatic or mild COVID-19 patients are admitted also in the hospitals. So ito po yung nakuha namin. So reasons for difficulty in referring out, we have lack of patient consent, especially ito yung mga private patients na ayaw pumunta ng TTMF, and then mga TTMF naman po, their refusal due to comorbidities, kasi nga some of the TTMF don't have the capacity right now to handle even mild cases. Ang kaya nila is to quarantine asymptomatic cases. So we have also distance far from TTMF, so ayaw ng mga pasyente na pumunta ng TTMF kasi mas malayo sa kanila. So they better go to a hospital. Then patient's choice, especially these are coming from the private hospitals. While delay in referral naman po is the lab results. As we recall naman po, some of the TTMF right now are only catering confirmed positive, so they don't admit suspect and probable. Otherwise, they have these lab results already in the PCR test. So reasons for not referring out, difficulty or tedious referral process and requirements. So maraming documents na hinihingi ng mga TTMF before they will receive patients. And the healthcare workers sometimes and next of kin prefer to stay in the facility kasi para mas malagaan nila yung kapamilya nila who are positive. So for the facilitators naman identified, dapat kailangan may MOA, so dapat there's presence of dedicated team that facilitate and handle all communication for referral process para mas mabilis yung transition, as well as travel po ng patient from and to hospitals vis-a-vis with the TTMF, and then the presence of the command center in local government units, because this time, last June, some of the LGUs already have this command center, a centralized mechanism for referral. Then for inhibitors po, some are with special needs, lalo yung mga children pregnant. As we know naman po, there's need for higher facilities or separate facilities or other services needed, lalo na pag elderly and child or pediatric cases po. So presence comorbidities na hindi kayang i-handle ng TTMF is one of the reasons, as well as the distance, lack of transport, or even the admissions. So in summary, ito na po yung ating findings from our focus group discussions. So sometimes may mga HMOs po yung patient na gusto ipa-cover, so gusto nila magpa-admit sa hospital. For the recommendations po, for the improvement of the health facility operations and services, so we need to further improve our teleconsultations. And of course, we need to link this to the PhilHealth so that we can reimburse the PF. So implement the patient monitoring from hospitals TTMF, so parang kahit CCTV lang connecting the TTMF and the hospitals. Encourage TTMF to establish OPD services, yung turnaround time din also of the PCR testing, and increase hospital capacity and capability for laboratories, and TTMF for the probable suspect. Well, for monitoring and sharing good practices, the Department of Health issued a department circular last 2 months ago to get the innovation and innovative practices and good practices of the health facilities. And I'm glad that most of our hospitals submitted their response to this call from the Department of Health. But if you want to submit further, we are glad to receive those good practices. You can refer to Department Circular number 2020-0303. The recommendation is to linkages and referral. So we need to streamline the TTMF admission process and requirements. So may mga ginawa na pong mga standards po dito na mga MOA, as well as I think the One Hospital Command is one of the response of the Department of Health to improve the linkages between facilities. And this is already operational na po. So as mentioned, may mga MOA na pong standardized, and if need technical assistance from the Department of Health, we are very glad to share this also with you. And then the mapping also of our hospitals and TTMF. And lastly, we are also glad that our Health Promotions Bureau also hear our call to come up with the communication materials to encourage patients in availing the TTMF services. And then it's good also din man na yung TTMF now is considered by the PhilHealth as reimbursable po yung operations nila by certifying the CIUs or the community isolation units po. And for the development and for the improvement further of this study to for deeper understanding in terms of how the LGUs and then the TTMF operates, we will propose to conduct a focus group discussion on this. So I think this is my last slide, and maraming salamat po sa lahat.
Okay. Thank you, Mr. Napulan, for providing us the current situation of the utilization of the temporary treatment and monitoring facilities, for sharing the factors affecting COVID-19 bed utilization and referral patients to these TTMFs, and being honest for sharing or identifying the gaps in the appropriate utilization of these facilities. The recommendations po are very well noted. Okay, thank you. At this juncture, we will be calling in Dr. Emerito Jose A. Faraon for his reaction on Mr. Napoleon's presentation. Dr. Faraon is an associate professor in UP Manila College of Public Health from 2011 until today. In 2019, he was awarded by the University of the Philippine System as the UP Faculty Grant Awardee from 2019 to 2020. Welcome to the forum, Dr. Faraon.
Good afternoon. I heard loud and clear. Thank you to our colleague, Mr. Rod Napulan. Thank you also for the invitation to be a reactor to this particular session. This is very enlightening. I congratulate Mr. Napulan for the comprehensive explanation of the temporary treatment and monitoring facility, especially during this time of the pandemic. I think the TTMF act as quarantine safe places for those with, as mentioned, the COVID-19 cases, suspect, probable, and confirmed, who are asymptomatic, just to deload our hospital facilities, which might be better focused on those with severe and critical cases. Earlier, just a brief sharing. Earlier in March 2020, the Commission, as you know, I am from the academe, the Commission on Higher Education also asked our assistance at the UP College of Public Health to come up with a some sort of public health guide for those higher educational institutions which happen to be volunteered by local government units nationwide to become, the term is different. They term it as community isolation units. But I guess there is somewhat a cross between a community, so they are known as CIUs, community isolation units, or the TTMFs. So basically, we had to give criteria on what would probably pass to be as a volunteer, and probably later on get the nod also of the local regional DOH office for it to become a TTMF. So by my reckoning, I think the TTMF determination is based also on the capacity, the space that might be provided, because first and foremost, we don't have these facilities before COVID. These are just already existing places. As Mr. Napulan has mentioned, there are even hotels which can be used now for such a new purpose that it should serve. So it can also be, I think, chosen based on the identification of the local government unit, if it was volunteered. So capacity means structural facility, availability probably of toilets, the space, probably air conditioning, open air, so that air could circulate well. One of my comments probably is that I noticed in the report of presentation of Mr. Napulan is that other than, well, to my thinking, other than having a fewer, because if you have fewer beds, therefore, like I have seen like Del Pan probably, or those facilities in NCR which have fewer number of beds, they tend to be occupied faster. So they have 100% utilization rate. So I think what do you think are as part of my reaction, what could probably be factors affecting optimization of utilization of this TTMF? And then I also saw that based on the research done by the focus group discussion, that distance and lack of transport are one of the inhibitors for the referral, and that really caught my attention. Wouldn't it be possible, as part of the recommendation also, that we should actually suggest to the LGU to provide or probably choose a TTMF that is nearer to where people are, or probably provide a transport assistance, so that they could probably be taken there, and that would ease the referral, because if that is the main complaint, then that could probably be a solution. So it's just both a question and a comment and a suggestion on my end as well. I also have another comment and at the same time a question. Would you also consider that if you are a patient who is asymptomatic meaning to say you probably a confirmed case, but you have mild cases, so rather than be detached to your usual norm, you would rather stay at home. So would that also be an inhibitor? Would you consider that patients would rather stay in home quarantine rather than go to a TTMF? So was that also explored? So that's my other comment, because I think for some time IATF commented that they will now prohibit home quarantine because, as you know, Filipino houses are not quarantine areas which are built to be large enough. And in this particular setting, a house is, of course, inhabited by people who probably do not have COVID. So it's not tailored to that extent. Of course, as you can see from the report of Mr. Napulan, there was some sort of underutilization of this TTMF, where the main purpose should also be it should be populated by the asymptomatic cases. So that was my last comment. Is it also a matter of the behavior of our people that they would rather stay at home, and how can we probably recommend that for the safety of your family members, why not stay in our TTMF? Because this is what the government and the Department of Health has provided. That being said, I commend again Mr. Napulan and our moderator for this presentation. Thank you. Hello? Hello po. Hi, Rod.
Thank you for that extensive reaction, Dr. Faraon. I think I would want to agree with your last statement na in the part of the government, we would always look after the safety of our people. So I think utilizing these TTMF facilities would be good when it comes to security. Okay. At this juncture, we will be entertained. I think Mr. Napulan would want to say something po.
Just to add the comments of Dr. Faraon. In fact, the government of the Department of Health also recognized the importance of TTMF. That's why in Bayanihan Act 2, there's a proposal of around 4 billion for the establishment of the TTMF as well as the community isolation facilities. So the directions of the government is really to improve the health facilities as well as the capacity right now, especially at the community level. And then
build new ones, you mean? Build new ones. Okay, that is great.
Yes, sir. That's why, and of course, we already asked how we can sustain this eventually. Since these are temporary facilities, that's why we are already proposing if eventually these facilities could be converted into a training rooms, or it could be also a evacuation area or evacuation sites, provided that the standard has been followed in terms of the infrastructure. Then, just to add, the data presented was last June. 2020. Just to inform everyone, after the study, because of some policy actions as well as developments, the occupancy rate of the TTMF was already improved, and then the occupancy rate of the hospitals were also been enhanced. And since based on the Bayanihan Act 2 also, that the private hospitals are required to allocate their 20% of their authorized bed capacity dedicated to COVID, and then 30% for the government hospitals. So with this, the occupancy rate of the hospitals as well as the health capacity systems capacity are already improving. So these are the developments of this study.
Okay, I think Dr. Faraon and Mr. Napulan already answered some of the questions, but I've seen po another interesting question here. Just recently typed in. This is question from Miss Lenny Rodriguez. Ask lang po, anong mga kailangan ng barangay unit para sa functional disaster office to help sa pandemic? Any new suggestions, please? Thank you.
Okay. So maybe we can share na lang po the administrative order in terms of establishing F. You can look into the standards of the Department of Health, and then second, I think there's a requirement from the DILG together with our MP on the establishment of the disaster unit. I think it's more the purview of the DLG if it's more of the disaster. While for the TTMF, we can share with you the policy po on this.
Okay, thank you, sir, for your answer. There's another question po. I hope you would still want to answer this. The question is, in terms of primary care in the context of COVID-19, is there a need to further push for a stronger primary care system in the country to avoid our health facilities to be overwhelmed?
Yes, that's why the Department of Health issued out a policy. First is the manual of the primary care facilities was also our bureau developed together with the other bureaus of the Department of Health. And then second, last May 14, 2020, the Department of Health issued out the Administrative Order number 2020-0019. It is the guidelines on the service delivery design of the healthcare provider networks. In this AO, it is highlighted the importance of the primary care facilities as the gatekeeper of our patients going up to the higher facility po natin na facilities. So it's very important that the primary care facilities should be established and be improved and enhanced. As all we know naman po in terms of our ratio for the barangay to population, we need to improve further kasi not all of the barangays are or have a barangay health stations. And then for the barangay health, for the rural health units, by the way, medyo malaki-laki po kung habulin natin in terms of our ratio. Our standard as prescribed in the 2017 to 2022 na PHFDP na dapat all barangays dapat is, I think we should have a barangay health stations para mas, kasi barangay health stations po mas malapit po yan sa community, mas malapit po sa bahay ng mga households po natin. And then for the rural health units, at least nasa 1:20,000 population po. So with these directions po, we can improve the service delivery network and as well as in compliance with the universal healthcare.
Okay. Doc, Mr. Napulan, thank you so much for that answer. Sir, I would just like to entertain one last question po. I think is a very good question. How the health-seeking behavior, I think referring to the Filipino people, be better sharpen up? That is the question of Miss Kathleen Grace Lentija.
A good point and concerns right now. With the enactment of the universal health care, we can see the importance of the health-seeking behavior of the community as well as of our population. With these directions of the UHC to improve and then improve the health education and promotions po natin. In fact, 1% of the DOH budget should be allocated for the health promotions bureau po natin so that we can improve further the health-seeking behavior as well as to educate our population in a proper with the appropriate facilities po. Kasi right now, we already observing na umarami na po and then overcrowded yung mga hospitals. But if you will look into their primary costs why they admitted, it seems na pang primary care po sila. For instance, most of our cases now ay mga normal spontaneous delivery and then which is supposedly nasa birthing facilities na po ito in the primary care level, especially if it's normal delivery. So dapat with this case we can improve the health seeking na dapat with these conditions. You should no longer go to higher facilities or in the hospitals so that you can be attended to. So with this, we need to educate our all the Filipinos on where to go to, and we need to navigate them in appropriate facilities.
Oh, okay. Thank you, Mr. Napoleon. I think my key takeaway for that with that answer po is that parang as a Filipino, we should bear in mind that the first place to go is the primary healthcare facilities. Okay, thank you. Dr. Faraon, would you like to give your answer po
I
or
think
commentaries?
it's a big yes. The Filipinos as part of the navigation, and actually to decrease, we all want decreased cost on the part of the government. That is the main difference between government and the private. Private hospitals always they say it's expensive, but they say that's of quality. What we try to strive is, of course, with the improvement and with the Universal Healthcare Act already enacted with its IRR, everything will improve on the primary level so that you will not get into that last step of already being chronically ill, needing more attention in a tertiary hospital, and that is more expensive, especially now that there is also a call that there is also a greater out-of-pocket expense. Out-of-pocket expenses will decrease if at the primary level, cases are already prevented from actually evolving into a chronic illness. And we should not burden actually think of the tertiary hospital as the talyer. You do not bring, if you have a car, if you have a transport conveyance, you know that part of the checkup is an annual oil change, an annual. So you also do that much more to your body. And that is the primary way of preventing anything that might happen that is more serious and more expensive. We don't want expense. We don't want to harm our body than it already is. So we should actually encourage our fellow men to consult at the first sign of any illness, not to the hospital, because remember our delivery network, it should start first. Everyone has a barangay health station, has a rural health unit in any part already. A lot has improved since Alma Ata. So since
Okay.
1978. So
Yes,
I think
okay.
it's a big yes.
Yes, the recommendations po are well noted. Okay,
Yes.
thank you very
Thank
much.
you.
Thank you for sharing your expertise, Mr. Napulan and Dr. Faraon. We will move on to the next presentation. The next presentation is the fourth and the last study to be this afternoon. This study aims to present the implementation of the Integrated Hospital Operations and Management Program, or the IHOMP. IHOMP is one of the flagship programs of Health Facility Development Bureau of the DOH. The program enhances the provision of quality essential healthcare services in the hospital through the improvement of management. Mr. Erickson Feliciano will be discussing the assessment of DOH Hospital on Integrated Hospital Operation Management Program. Currently, Mr. Feliciano is the Development Management Officer 4 in HFDB. He is also the National President of the Mother and Child Nurses Association of the Philippines Incorporated. To know more, the present picture of the implementation of the program, let's welcome Mr. Erickson Feliciano. Good afternoon, sir, and thank you for joining us today.
Thank you for that kind introduction, Ms. Michelle. And good afternoon to all our participants. And I'd like to take this opportunity to express our gratitude to all the organizers of the National Health Research Forum for Action for the opportunity to present this research paper from the Health Facility Development Bureau, which is entitled Assessment of Department of Health or DOH Hospitals on Integrated Hospital Operations and Management Program, or IHOM. With me are the co-authors of this research paper, Ms. Diane Melody A. De Rojas and Mr. Roderick M. Napulan, our previous speaker, with the guidance of our Bureau Director, Director Maria Teresa G. Vera. So what is IHOM? IHOM is a very common acronym and has almost been a household name for our DOH hospitals. IHOM stands for the Integrated Hospital Operations and Management Program. It is one of the flagship programs of the Health Facility Development Bureau of the DOH. And just to give everyone a short information about our bureau, the HFDB is the office that assumes technical leadership in the development of plans, programs, projects, standards, and technical leadership on policies and coordination, as well as provision of technical assistance, capability building, and consultations related to health facility planning, development, maintenance, operations, and as well as management. Uh, to be able to provide guidance to the hospitals, the IHOMP was developed by the Bureau to enhance the provision of quality essential healthcare services in the hospitals through the improvement of management systems and procedure within the healthcare facility. iHomp is relatively not a new program in the Department of Health. In fact, it was issued as a policy through Department or Administrative Order number 44-A series of 1999. So the iHomp was formerly called the Hospital Epidemiology Program and was reconceptualized in 1995. It was also expanded in 1997 in response to the present information needs and evolving requirements among the hospitals. Now, what is the goal of the iHome? The goal of the program is to enhance the roles of the hospitals through the improvement and management systems and procedures within the said hospital. Now, we need to have the tool to be able to implement the program. And in response to that need, the Bureau developed the iHome self-assessment tool, which is flashed on the screen. Now, it was developed by the HFDB to provide guidance for the proper assessment and evaluation of hospital operations, management, and to identify the strengths and areas of weaknesses that require improvement among the health facilities. Now, there are 6 major components of the iHome assessment tool as flashed in the screen. First is the governance. Actually, the perfect score for the iHome assessment tool is, of course, 100%. The governance accounts for 20%. Another major component is the performance of the hospital in terms of ethics and patients' rights, which is also 20%. We also, through that tool, we also assess the quality, measurement, and improvement of the health facility. This accounts to 15%. And another 20%, which is a very important component as well, is the patient safety or how the hospitals deliver quality and safe services to the people. We provided 10% for facility safety and emergency management because, as we all know, we need to have the facility ready in terms of disasters such as COVID, and also resource management, which accounts to 15%. We find the resource management very important at this point because of the COVID-19 pandemic. We are really challenged. The hospitals and other healthcare facilities are challenged to improve on resource management because of the current COVID-19 pandemic. And as you can see, I attached here the sample of our tool, the iHome assessment tool, wherein the different components were listed on the leftmost part of the tool. Now, there are questions to be answered, and the questions pertain to the standards that are required to be in place. To be able to identify the data source or the standards and the unit in the hospitals that need or where we can gather the data, we put there in the data source and point of emphasis to be able to identify which standards are already in place and are being implemented. There are corresponding scores into the tool and into each question that, for example, in the governance, there are several questions that will lead you to score the hospital for at least 20 will be the highest for governance. Now, I'd like to present to you the objectives of this study. The study aims to achieve the following. First, we would like to determine the status of implementation of the integrated hospital operations and management program of or iHome of the 66 DOH retained hospitals. With that, we will be able to identify the key strong areas and weak points or those areas needing improvement using the 6 major components that I mentioned of the iHome self-assessment tool. And this will be
used to provide recommendations to improve hospital operations and management based on the data gathered and study findings. The figure shown here is the research paradigm of the assessment of the hospitals using the iHome self-assessment tool. So we administered the tool to the 66 DOH retained hospitals, and based on the data gathered from the DOH hospitals on the 6 components of the iHome tool, we will arrive at the recommendation which will be the basis for policy improvement to improve the performance, operations, and management in the health facility. This research employed descriptive design and utilized the instrument discussed earlier, the iHome self-assessment tool, administered to the participating hospitals. And to be able to arrive with our findings and recommendations, we use mean, standard deviation, percentage, and the analysis of variance, or ANOVA, as our statistical methods. Actually, the data collection was part of the Department Memorandum issued last January 14, 2020. So this is DM number 2020-0013. This is the online completion and submission of hospital reports. Initially, the Department Memorandum served as the basis for the computation of the MOE of the hospitals. However, with the very good turnout of submissions from the DOH hospitals, we decided to turn it into a research paper so that we will be able to analyze and assess the findings and the data gathered from the data collection. And we find this to be very useful when we do our planning and provision of technical assistance to the healthcare facilities. Now, this the iHome assessment tool or self-assessment tool I presented earlier was translated into an online version. So the iHome assessment tool translated, to translate the tool, we utilized the Google survey form, and the link was sent to all the healthcare facilities for them to be able to input their responses to each question on the 6 major components. And as part of the data collection, we also requested the hospital to provide us with their basic hospital profile or information. This basic hospital information will be used later on as basis for our analysis of the findings of the research. Okay, so allow me to present the research findings based on the data gathered from the 66 DOH retained hospitals. The first is, I'd like to show to everyone the overall iHome performance of DOH hospitals. This pie chart shows that 98.5% or 65 out of 66 DOH hospitals scored more than 75 in the iHome self-assessment tool, while only one DOH hospital, or around 1.5%, scored below 75. And in the legend below the pie chart, you can see the 50 and below, 51 to 74, and 75 and above. Just to inform everyone, the HFDB utilizes score interpretation as well as corresponding interventions. For 50 and below, the hospital would require urgent referral through assessment and provision of technical assistance by the Health Facility Development Bureau. If the hospital scored 51 to 74, that means that the hospital will be required to submit their action plan to address the non-compliance. The DOH CHDs through the Health Facility Development Units. The HFDUs are our regional counterparts. They also provide technical assistance to these healthcare facilities who scored 51 to 74. But we can also provide, the technical experts of HFDB can also provide technical assistance upon request of the HFDU and the facility requiring the assistance. For those who obtained score of 75 and above, it means that the health facility is doing well. So we would like to commend the good practices of these healthcare facilities, and we require them to submit their own action plan so that we will be able to utilize them for continuing quality improvement. Now this bar graph shows the IHOP performance of the OH hospitals by level. So we also categorize the scores based on the hospital level or classification. And for everyone's information, the Licensing Bureau or the HFSRB classified the hospitals according to their capability or level. So with level 1, 2, and 3, level 3 being the highest or having the highest classification as a teaching and training institution. And based on the figure shown here on the screen, level 3 DOH hospitals posted highest IHOM score with 93.5%, followed by level 2 hospitals with 91.79%, and lastly, level 1 hospitals with 89.41%. So utilizing the p-value of 0.05, we arrived at 0.02, which means that there is statistical significant difference between the score of level 1 and level 3 hospitals. So as you can see in the trend, the higher the level of the hospital, the higher is the score in terms of IHOM self-assessment. The data that we obtained were also descriptively analyzed according to the geographical locations of the hospitals. And based on the table shown here, the regions where the OH hospitals scored highest in IHOM are as follows. First is Calabarzon or Region 4A with 97%, followed by Region 1 or Ilocos Region with 96.83%, and Cagayan Valley is third with 95.50%. The lowest scores of the OH hospitals were posted in Mimaropa or Region 4B with 84.32%, the Eastern Visayas or Region 8 with 88.50%, and the Cordillera Administrative Region with 89.12%. Very important also is to disaggregate the findings or the responses of the DOH hospitals into the 6 categories or components of the IHOM assessment tool. We disaggregated and analyzed each component and found out that the DOH hospitals scored highest in resource management. So as mentioned, the total is 15. They got 14.21 or 94.73%. Second will be the governance with 18.75 out of 20, which accounts to 93.75%. And of course, we also would like to note that they scored lowest on ethics and patients' rights with 18 out of 20 or 90%, followed by patient safety with 18.15 or 20 out of 20 or 90.75%. And if you can see in the bar graph, from highest to lowest, the ranking will be number 1, resource management, followed by governance. Third will be facility safety and emergency management. Fourth is quality management and improvement, patient safety and ethics and patients' rights. Okay, so lastly, I'd like to share with everyone the comparative analysis of the IHOM components by hospital level, wherein we use mean, standard deviation, and of course analysis of variance to differentiate the responses and the scores of the different levels of health facilities, utilizing the measures of the 6 components of the IHOM assessment tool. And those with asterisks, of course, we find significant difference, particularly with that score of level 1 and level 3 facility on patient safety and resource management with p-value of 0.0015 and 0.008 respectively. Now, we do not find significant difference on the scores of the different levels of health facilities in terms of governance, the ethics and patients' rights, quality improvement and management, as well as facility safety and emergency management. In conclusion, majority of the DOH hospitals perform well on IHOM assessment. The higher the hospital level, the higher the IHOM performance. And as previously presented in the pie graph, almost all of the hospitals scored higher than 75. So that means that it is a very good performance among the DOH hospitals in terms of IHOM assessment. For hospital management components, we need to consider this as the strong points of the hospital because this is evidenced by the high scores that were obtained in terms of governance and resource management. So very important is this finding also at this time of the pandemic, because as mentioned, resource management is one of the top priorities. And lastly, we also would like to conclude that the delivery of services may be improved in areas such as patient safety, ethics, and patients' rights, because these are the components where the DOH hospitals scored the lowest. From the findings and analysis of the data gathered from the DOH hospitals, we arrived at the following recommendations. First is we would like to have a compilation of good and commendable practices of DOH hospitals based on the IHOM components. Now, this will be the basis in reviewing and revising the existing IHOM policies, because we need to revise the existing 1999 issuance on IHOM. But we constantly improve the IHOM assessment tool by issuing department memorandum in 2017, and just this year when we asked the hospitals to submit the IHOM assessment tool online. The DOH shall also provide assistance to lower level health facilities to improve capability and enhance operations and management. It is because of the findings that the higher the capability of the hospital, the better is their IHOP score. Now, this is especially applicable to level 1 healthcare facilities, because we shall be able to improve their capability and in return improve also their performance. And we'd like to put emphasis on the areas needing improvement among these hospitals. And the improvements that we are recommending are actually aligned with the goals of the Philippine Health Facility Development Plan, or the PHFDP, which is to improve the capability and the services being delivered by the DOH hospitals. Third is provision of capacity building and technical assistance that shall be prioritized for hospitals to improve their performance. We'd like to also take note that there are the HFDUs have been trained to provide assistance, and also the hiring and training of technical staff as hospital counterparts of the HFDB. We actually started hiring and training our hospital counterparts, or the HFDU counterparts in the different DOH hospitals. And as an update, the HFDB has sub-allotted approximately 25 million pesos for the hiring of the HFDU counterparts in the DOH hospitals. So we aim to that these HFDU counterparts will be able to assist our DOH hospitals and improve their performance on IHOM and other HFDB related programs. We also propose that this study may be expanded to include the performance evaluation of LGU and our private hospitals. We have drafted and we aim to issue other policy that would encourage the LGU and private hospitals also to utilize the tool and be able to participate if they would want to be provided with updates. And lastly, is to explore inclusion of IHOM scores as criteria for the DOH grant-based incentives for hospital. These grant-based incentives are for the DOH retained hospitals, but for private and other government health facilities, we would like to inform you that by utilizing the IHOM, this will give you a platform to access the other resources of the Bureau, such as provision of technical assistance, and we can also provide reference materials or manuals and copies of issuances from the DOH. This will be very useful for assessment and program implementation towards quality improvement. With that, I'd like to thank everyone for your time, and I would like to thank all the organizers of the National Health Research Forum for Action. Maraming salamat po.
Okay, thank you for that presentation, Mr. Erickson Feliciano. Sir, I just want to put an emphasis on the IHOP assessment tool usage. Actually, you're right, sir, that this tool can lead to the development or establishment of commendable practices in the DOH hospitals. And second point, right now you're developing or you're capacitating technical staff in the DOH hospitals. Okay, I think that's a good development. Okay, thank you very much po. From this point, I would like to call in again Dr. Faraon to give his reaction on your presentation. Hi again, Dr. Faraon. Okay po.
Magandang hapon po uli. Maraming salamat, Michelle. Thank you, Mr. Erickson Feliciano, for that study and in-depth look on the performance of the iHome. iHome is the key word there, I think, is the integrated. We all long for an integration of all the data that we receive all day. And since I'm also in the management, we teach Master of Hospital Administration. I think this is very good material as we teach our future hospital managers. So the way I look at it is that almost or more than legal age na itong si iHome. Kasi 21 years 1999 pa to na-establish. So I think it has provided the integration needed in hospital operations and management needed. As you know, decision making is very difficult to do for managers, especially without data. Data must always be updated, and that is very critical when you are trying to manage resources daily, especially in government hospitals. And looking at that, you are given a budget yearly that you must spend wisely, but how do you do that without iHome? So I think iHome is really very critical in helping our hospital managers in deciding how to effectively allocate available resources, especially during times of shock like what we have now during the pandemic. So shocks like this are unexpected. You did not actually put it in your past budget, so you must really be prepared because you do not know the extent of how much damage or how much challenges it will present to your system. So I am particularly I have looked at the results, the 6 components mainly, which you mentioned: governance. I think it was ethics and patients' rights. Of particular note also to me was the quality measurement and improvement, because in the academe I also teach about healthcare quality management, which is I think most often the neglected part when we deliver our universal healthcare services, because we always try to make it affordable and accessible, and the main thing usually is quality. Is it really of quality? So I think iHome provides that quality measurement and assessment on a regular level. You also mentioned about facility safety, patient safety, and I think resource management, which is very important. I would just like to note that you mentioned that the lowest scores in your study were from Mimaropa, CAR, and Eastern Visayas. But if you look at the whole picture of all the scores, I'm a teacher and always give exams. Your lowest score is still in the mid 80s and near 90s. So I think it's quite high. So I don't think your low is really low. And as you said, I think it's still good performance considering that 20-year run of iHome. But for your, in your knowledge, and this could be part of what you could probably comment on after I end this reaction, what accounts for the probable mid-80s and near 90s, the low scores of these particular hospitals found in Mimaropa, CAR, and Eastern Visayas? And with the 2 other components that you have pointed out, like patient safety and patient rights, I think while they are still high for me because they nearly are at 90%, it's a question mark for me. Maybe another study might take a look at this. Why is it that we have a low score there? What about patient safety? Because as you know, our greatest customer our greatest end user are the patients. So anything that has to do with them, and when you talk about quality, the focus is always on them. So when it's their rights and safety, what could probably be causing that? So two things: the one about the lowest scores that you observe in the geographic areas mentioned, CAR, Eastern Visayas, and Mimaropa, and as well as the focus on the 6 components, the low scores with regards to patient safety and patient rights. What could probably be the reason? Was there a probable disaggregation made within the disaggregation data that you already presented? That what about it? Was this about accidents? Was this about infections? So and if not, probably another study I would suggest could probably take a look at this. Because the end point, I think, of all this monitoring, this assessment that we are doing, and the usefulness of this would be always the translation to policy and a health outcome that we all want, which means all the endpoints of what you see in universal healthcare, which is a responsive health system, lesser financial catastrophe, and providing your health outcomes that are actually the vision also of our Department of Health. So that in essence is my main reaction to your report. Again, I thank you. Also, I think Mr. Napulan is also part of this study. So thank you for this particular added information. And we look forward to the 19th National Health Research Forum for action. Thank you very much.
Thank you very much, Dr. Paraon, for that very well thought of and comprehensive reaction to the presentation. And we're also surprised that the patient safety, as you mentioned, as well as the ethics and rights are scored lowest. But as you mentioned, your reaction is very accurate that the scores are actually not low. We're pertaining into the 6 components or the ranking, which means that all the DOH hospitals scored more than 80 on this. And these are good indicators or good scores for them. But in terms of the ranking, the 2 are the lowest in terms of the iHome self-assessment tool components. And just to also emphasize the point of Dr. Paraon in terms of patient safety, and also I have read in the chat box the question on the patient safety. We also noted that some of the comments also from the tool or the responses from the tool is that the hospitals do not have, some of the hospitals do not have dedicated staff to manage patient safety. So that means that most of the hospitals have patient safety officers who were designated as part of only their add-on task, which means that patient safety is not the sole responsibility of these patient safety officers. So that's one of the major problems with patient safety that we really would like to address. And if there are dedicated personnel for patient safety, then definitely the program will run better, and we hope that it will improve the provision of safe and quality care to our patients as well. So to respond also to the query about the involvement of the patients, actually this tool has been validated and utilized for several years now, and we have trained our health facility development units or our regional counterparts to validate the data as well. So since this is a self-assessment tool, we also ask the help of our HFDU counterparts to help us validate the scores being provided by the hospitals in the self-assessment. So we hope that the findings of the study will be able to give us insights on which of the programs of the HFDB would like to focus on in the coming days or months, so that we'll be able to provide more technical assistance to these healthcare facilities.
Okay, thank you, Mr. Feliciano, for initially addressing some of the questions and concerns of our participants. I would just, at this point, I think it would be much better if we're just going to entertain 2 last questions. First question is, are private hospitals required to implement IHOPE? How about clients of the LGU hospitals?
Okay, so thank you for that question. Actually, as mentioned, we only required or asked the DOH retained hospitals to uh, complete and submit the validated iHome self-assessment tool. But with the issuance that the Bureau is drafting, we'd like to encourage also participation of the private hospitals and other government hospitals as well, because we find this program very useful to DOH hospitals and would like to expand also this study to other healthcare facilities. And as mentioned, we wish to issue this policy for them to be able to, para siya, it will be like the platform for them to be engaged with the program of the Bureau. Because as mentioned, this is integrated, or the iHome, it integrates all the operations and management system in the healthcare facility. If the by merely using the tool and assessing which of the key areas they need to improve on, then we'll be able to provide assistance to the private facilities as well as the LGU hospitals. So we hope to release the policy this year and as part of the recommendations of this study as well. So that's a very good question.
Okay, thank you, sir. One last question po from Ms. Maria Victoria Rondares. The question is, how much of assistance to lower level health facilities is warranted? Should residents provide manpower to level 1 health facilities? Should
Okay.
supplies come from tertiary hospitals for this level 1 hospital?
Okay, thank you for that. As mentioned, it's not just about financial assistance that the program would like to emphasize. But in terms of financial assistance, as mentioned, we have provided a total of approximately 25 million to the healthcare facilities for DOH, at least for DOH retained hospitals. These funds will be used to hire and train the counterparts who will be assigned in the DOH hospitals. But for other healthcare facilities, by using the tool and by implementing the program, they will have access to the resources also of the Bureau, not just financial resources, but other important materials as well. We can provide them technical assistance. We can also provide resources and even the manuals the manuals for the standards of the healthcare facilities that are being developed by the Bureau. It's actually the HFDB that develops this manual of standards for different services in the hospitals. We have manual of standards for nursing services, medical social work, pharmacy, emergency department, infection prevention and control, finance management manual, and all other services in the hospital. So I think that this assistance to the health facilities will be very important for them to improve, aside from the provision of financial assistance.
Okay. These hospitals, these units will be expecting more technical assistance from COH. Okay. Thank you very much for answering the question. And to Dr. Faraon as well, thank you for your energy and passion to answer questions. Thank you, sir. Okay.
Thank you very much.
Thank you,
Thank you.
Mr. Feliciano, Dr. Faraon, for sharing your expertise with us today. Thank you very much. We will proceed to the next part of the session.
Thank you.
We are now nearing the end of the session 3, part 1. The discussions have been enlightening and have served as driving force to conduct more researches that will improve the health service delivery for the Filipinos. This is a fact. If we want to further advance and improve our lives, we need to do more research that will greatly benefit the society. The Health Facility and Development Bureau is one of those which take on the initiative. They have launched a research call on health facility development operations and management researches. This afternoon, the Bureau will be awarding research grants to the selected health facilities. Joining us this afternoon, Dr. Maria Teresa G. Vera, the Director of Health Facility and Development Bureau, together with Mr. Roderick Napulan. Welcome to the forum.
Thank you so much for this opportunity to announce our shortlisted researches. But before we will proceed with the announcement, may we have a background first. So the Health Facility Development Bureau, through the Research and Performance Management Division, we envision the Health Facility Research and Policy Innovation Hub that aims to produce researches related to health facility development, operations, and management. So last January, we called for submission of the research proposals through the Department Memorandum Number 2020-0061. So we aim to encourage everyone, especially in the facilities, to submit their proposals to us so that we could improve the evidences in terms of developing policies and plans. So there are 6 themes that we look into. We have the health outcomes and hospital infection rate improvement, waiting time and turnaround time reduction. We have the out-of-pocket expenditures reduction, improvement in patient confidence and trust in accessing healthcare, and the baseline data and evidence-based generation for health facility standards development. And lastly, on the health facility operations management, efficiency improvement. So these are the themes that we look into from the proposal submitted to us. So just a quick summary, the total budget request from us is 54 million pesos. 50 research proposals heard our call, and then by affiliations, most of this came from the DOH hospitals, and some private institutions also submitted their request. So to announce the 15 shortlisted research proposals, may we request our Director, Maria Teresa G. Vera, to announce the following researches.
Thank you, Rod. Good afternoon to all. So it's my honor to present to you the 15 shortlisted research proposals out of the 50 proposals that we received. So please take note that the proposals that I'm going to present today, it's not ranked. So we'll just go through each of the proposals. So first is the rate of healthcare-associated infection after implementation of intravascular line maintenance care bundle at the neonatal intensive care unit. The proponent is the Philippine Children's Medical Center. Another one is infection prevention practices among non-allied medical workers, submitted by James Gordon Memorial Hospital in Olongapo City. The third is how dirty are our stethoscopes and sphygmo manometer at Southern Isabela Medical Center. Its implication to infection control and patient safety, submitted by Southern Isabela Medical Center. Another proposal that was shortlisted is time and motion study of certain hospital frontline services processing time in the provincial and district hospitals of Iloilo, basis for the time management plan, submitted by the Hospital Management Office, Province of Iloilo. Another proposal is the influence of readiness and inpatient processes through a timely discharge process in Adela Cerati Memorial Medical Center. Proponent is Adela Cerati Memorial Medical Center. Next is improving emergency room turnaround time, the Northern Mindanao Medical Center experience, submitted by Northern Mindanao Medical Center. Another is the association of the patient satisfaction and turnaround time of the outpatient services at a tertiary hospital in Bacolod City, submitted by Corazon Locsin Montelibano Memorial Regional Hospital. The other one is submitted by Epimetrics, evaluating the utilization of Lean Six Sigma on reducing patient waiting time in the outpatient department. Another research proposal is the time and motion study of medical emergency services in tertiary government hospital, submitted by Ilocos Training and Regional Medical Center. Another proponent is the Corazon Locsin Montelibano Memorial Hospital, who presented the analysis of PHIC reimbursement processes and its effect on outcome and claims in Corazon Locsin Montelibano Hospital, and the application of change management protocol or network model, a 3-phase study to increase efficiency. Here's the number 11 listed here as the proponent. I want to correct the proponent. It's not Epimetrics, but rather Batangas Medical Center. The title of their proposal is Batangas Medical Center of the Out-Pocket Expenditures of Patients under No Balance Billing Policy in Batangas Medical Center, a 3-year review. The next proposal, I would like also to correct this because the correct title is Compliance to National Standard in Infection Control of All Government and Private Hospitals in Region 8. The proposal was submitted by Eastern Visayas Regional Hospital, CHD. Another proposal is evaluation of the electronic human information system implementation at the outpatient department of Baguio General Hospital and Medical Center. Proponent is the Baguio General Hospital and Medical Center. Second to last is reduction of return to hospital and denied PhilHealth claims of Valenzuela Medical Center submitted by Valenzuela Medical Center. Last but not the least, came from the Ministry of Health, BARM. So improving, the title of which is Improving Healthcare Systems in BARM, Status, Challenges, and Direction Towards Sustainable Development. So before I end, I would like to thank the organizer for allowing us to present the 15 shortlisted research proposal. Thank you.
Thank you, Dr. Vera, for that presentation. This will surely encourage the DOH hospitals and other health facilities to do more research.
Just to add to our director, so just to give you the next steps for this. So next week we will be having a final selection of the research proposals, and then awarding of grants will be provided by second week of October, and then we have 2 phases of implementation of this since most of the researches were being delayed because of the pandemic. By first week of November, we're already starting release of funds for those who can able to disburse and obligate the funds that we will be allocated to them. And then by January 2nd week, we also provide the second tranche of the funding. Since there's still 487 participants still here, I just to give you an advance information that we will be having a second round of a call for research proposals. So please stand by, and we will send out the department memorandum for everybody to submit their proposal for the 2021 implementation of the research. So the tentative deadline of this is on December 15, 2020. And just to for you able to have an update, so kindly look into our Facebook account as well as in our email address, so you can check or use the QR code here so that you can be directed to the Health Facility Development Bureau website as well as the Facebook account. So we'll be posting the updates on this, so please subscribe to us. Thank you very much.
Okay, thank you, Director Vera and Mr. Napulan. We are now at the end of session 3, part 1. We would like to thank everyone for joining us today. This afternoon, we have heard the presentations on HRH Master Plan Strategies for 2020-2040 for Universal Healthcare, HRH projections in support of the National Health Human Resource Master Plan, and the third study presented by Mr. Napulan, optimization of COVID-19 health facilities, and the fourth study, assessment of DOH hospitals on integrated hospital operations management program using the IHO tool. Tomorrow we will continue on the session 3 entitled Ensuring Continuity of Health Service Delivery Amidst Public Health Services, zooming in to the special populations, the overseas Filipinos, the children, and the elderly. We're hoping to see you tomorrow. Just few reminders. If you have encountered problems during the webinar, lost connection, or did not finish the webinar, links to the webinar replay will be sent to your registered email address. Second, to receive a certificate of completion for this webinar, please take the quiz and answer the evaluation via the link which will be sent to your registered email address a day after the session. The third reminder, participants are not allowed to take the quiz, are only allowed to take the quiz once. You need to score 80% or higher to receive a certificate of completion. Otherwise, you will receive a certificate of attendance. The last one, if you only wish to receive a certificate of attendance, just go to the link that will be provided to you via email. Good afternoon. Then the fifth reminder, the webinar quiz will only be available for the next 48 hours after the links have been sent. After the quiz is closed, your certificates will be issued at a later date after verification of scores. As a final reminder, please double check your email address during the registration. Incorrect email addresses will not receive related announcements. Good afternoon, everyone. Thank you. See you tomorrow.
Thank you very much, Ms. Michelle Daabay, for moderating our session for today. Just some upcoming NHRFA sessions. Again, tomorrow we will have October 7 from 1 to 4 p.m. And also on November 12 and November 13 from 9 in the morning till 12 noon. To register for our NHRFA sessions after filling in the registration, please make sure to register to Webinar Jam to gain access to the webinar link. To do this, just click the link provided for each session to register to Webinar Jam. Once in Webinar Jam, please click the register button seen at the bottom right corner of the page. Fill out the form and click the Register Now button. Please make sure and double check that your email address is correct. Wrong email addresses will not receive the link to the webinar. You will be provided a link to the webinar. Please take note of this, and you will go to this link on the day of the webinar. In addition, after a few minutes, you will receive an email containing the webinar link and registration confirmation. You will also receive an email 15 minutes before the webinar to remind you that we are about to start. For questions, comments, or inquiries about the 18th NHRFA, please send an email to naharfa2020@gmail.com. For inquiries about registration and certificates, please email us at naharfa.ituro@gmail.com, and our IPC Ituro staff will be able to assist you with your concern. Again, thank you very much for joining us today for Session 3, Part 1 of the NHRFA 18, Ensuring Continuity of Health Service Delivery Amidst COVID-19, Human Resources for Health and Health Facilities. This has been IPC Ituro, DOH, and DOST PCHRD thanking you for joining us for today's session.